about a drug abuse wheel. So if you think about drug of abuse as a wheel, okay, and you can classify the drugs that you have into stimulants, empathogenic, psychedelic, dissociative, cannabinoids, depressant, and opioids. And what you do is stimulants. What's the stimulants? The drugs that give you the high, they become very energetic, you want to fight the whole world, and those are the stimulants. And you have the depressant, make you feel relaxed, chill, buzzing. The opiates make you feel confident, invisible. The psychedelic give you the spiritual trip and feel your senses are highlighted. The cannabinoids, stoned, calm, the munchies. And you have the dissociatives, the out-of-body experience, euphoric and floaty, like you're floating in the sky. And empathogenic, you feel loved and you feel cuddly. I'm making it very appealing, aren't I? Anyway. So if you look at the outer circle, this is the old drugs. And the inner circle is the novel psychoactive. So these drugs, I'm not going to dwell into this too much, but you can see a lot of drugs coming into the markets, and this is just probably 2% of the drugs are there. The list goes on and on and on and on. And what are they? What's the novel psychoactives? These drugs are being brought to the market to bypass drug laws. So if the drug law say you can't, cannabis is or cocaine is class A drugs or it is illegal, they will change the structure and they will go into making a new drug that's not covered by the law. If you can look at amphetamine and you can look at the ephedrine, it's almost similar structure. Just change one atom to another and Bob's your uncle. And you bypass the law. So why they are a problem? The second, you go back to the same question. Because nobody knows what you're taking. The guy who's selling you the drug doesn't know what he's selling you. The guy who's making it doesn't know what he's making. The guy who's using it doesn't know what he's using. The adulterations, there is no quality control. And you can look at the user websites, and there's some drugs testing websites. You can send them the drugs in Europe and America, and they test it. And you'll be amazed what you find in these drugs. So, and some of them, they have paracetamol in them, all of it paracetamol, some starch, and some have a mix of these drugs, which is very, very lethal. So what do you need to know? So I'm now scared you enough to tell you that there is hundreds of drugs out there. You're not going to remember every one of them. You're not going to remember what is each one of them going to cause. What's the clinical feature of each one of them? No. So for you, do you need to know what is this drug and what's the problem with these drugs or not? Now, another thing I just want to mention, and I don't know what's in the situation in Turkey, but for example, in UK, where I used to work, the single substance has different names, and one name applies to a different drug. So Molly to you, not Molly to me. And this is a huge problem. So do not rely, when as a physician in ER or toxicology, do not rely on the name they tell you and say, oh, that's Molly, oh, that's ecstasy. No, it doesn't mean that. So moving forward, you don't need to know what's the drug. As a physician, just classify what's the drug that you have, okay? What's the patient coming with? Is he coming unconscious, sedated? Is he hallucinogenic? Or is he in a stimulation effect? And that's what you need to know. And accordingly, the good news is you don't have an antidote, okay? You just need to support them. So as a stimulant, what they're gonna be? Tachycardic, hypertensive, agitated, ECG effects, metabolic acidosis, and that's the nutshell. You have something is super stimulant, okay? The depressants, they're gonna be sedated, unconscious, comatose, ataxic, etc. The hallucinogenic, the traditional hallucinogenic give you the panic attacks. They feel that they are hallucinating, and usually the problem with them, the traditional hallucinogenic, is the self-harm. Okay, self-mutilation. They think they can fly, and he end up jumping and killing himself. But the new ones are associated with some stimulants effect. So be worried about that. There was a reason why I put these three circles twined, because a stimulant can give you a depressant effect can give you a hallucinogenic effect. So you need to be careful with that. So generally what I do, as a physician, I've treated loads of these patients. I just keep it to ABCD. I just support the care of the patient. Any patient comes to me, I look at them as, this is what I'm gonna do. I'm gonna protect your airway, breathing, circulation, disability, etc. Automatically, I look if they had a fit or they're fitting, I support that. Fever, whatever they come with, I keep an eye on temperature, and I tell my nurse, keep an eye on the temperature. I will tell you why in a minute. CK, always do your CK because of rhabdomyolysis, and clonus. This is my tradition. I just go there and do these things and documented them, and I keep reassessing this. And so far I've been okay. So far, and my patients are being okay. So, management, we said supportive. I'm not gonna go dwell on these slides too much, but a couple of things I want to illustrate. For agitation, confusion, your benzodiazepine is your friend and the patient friend. Give them loads of it. I'm not very big fan of antipsychotics, and from my experience, I would not recommend it. You don't know what they've taken, you don't know what the tablets they've taken contain, and you ended up giving them antipsychotics, you're ending up with interaction. Probably don't want to do that. QT prolongation, yesterday they talked about this stuff, so I always keep to benzodiazepine, maybe if you want to use ketamine, and if it is severe enough, you can consider sedation and intubation. In terms of tachyarrhythmias, unless your patient is having a serious tachyarrhythmia with hemodynamic compromise, leave them alone. I had patients with sinus tachycardia, SVT of 180, 190. I would not treat them. It's most likely driven by the sympathomimetic effect. Give them benzodiazepine, they will calm down, and the heart rates will come down. You end up giving them adenosine, this, you're going to make it much worse than what it is. And again, now, regarding the temperature is a big problem with novel psychoactive, especially stimulants, and we don't know why. Why they become hyperparexic. Hyperparexia kills in novel psychoactive. They give you multi-organ failure, and I've seen it in front of me. Within a couple of hours, you see the clotting factors goes off, you see the LFTs goes off, you see the UNEs goes off, and you are into no man's land. It is a big problem. Your patients with temperature, you need to treat them very aggressively. Nobody knows why temperature happened. Is it serotonin syndrome? Is it monoamine oxidase inhibitor? Is it adrenergic effect? Is it peripheral effect? Probably it's a combination of a lot of things. I'm not going to dwell too much on it because of lack of timing. But what you need to do, you need to cool your patient down, and you need to be over them like a rash. Don't let the temperature goes up. If your patients start to have the 38, be alarmed. Bad news. Start to calm them down, because the agitation will drive the temperature up. Sedation, benzodiazepine, mists, whatever you have, cold fluid, bladder irrigation, ice bath, etc. If the temperature continues to goes up, that's bad news. Intubate, ventilate, and paralyze your patient. You don't want the temperature to start to go to the 40s. That's associated with very high mortality rate. If there is a lot of muscle contraction, you can start dantrolene. Dantrolene is being used for malignant hyperthermia. As you know, it's because of the genetic defect in calcium channel ryanodine receptor 1. And you can give them dantrolene to block the receptors and to block the release of calcium from sarcoplasmic reticulum. And you drive because what's happened when the muscle contract a lot, that generate a lot of heat. So you counteract that effect. Serotonin syndrome, again, it's a very important subject you need to be fully aware of. Fortunately, I can't go through it. You sure? Okay. That's kind of you, thank you. So serotonin syndrome, what we're talking about here is surge of serotonin in the CNS, and it has a triad of mental health alternation, confused, drowsy, hyperexcitability, neuromuscular hyperexcitability, the clonus, the hyperreflexia, okay? And number 3 is autonomic instability, hypertension, tachybradycardia. And we've seen quite a lot of these. You usually see them with patients who are on antidepressants, who use too much of it, overdose on it, or use 2 or 3 antidepressants, or overlap the antidepressant without a good washout period. But we've seen similar picture. I don't know whether it is a pure serotonin syndrome or a combination of other things with these novel psychoactives. You need to be very careful of this. So hence, when I said initially, that's what I do in managing these patients. I support care, I support them, and I always keep at clonus and the temperature and the CK to make sure that I'm not missing serotonin syndrome. And it is a cascade. Serotonin syndrome is a cascade, and it starts with altered mentations, as I said, hyperexcitability, and then it goes to hypothermia. And full-blown serotonin syndrome is associated with high risk of morbidity and long hospital stay, and also mortality if it is not recognized. So what you do, you stop the offending drug, you support them, benzodiazepine. Now, it's a very important point. Traditionally, if a patient comes to me and said, I have taken a lot of citalopram, antidepressant, I would consider giving them cyprohepatidine or chlorpromazine if it is severe enough or if I think it's warranted. Usually, when you stop the medication, you give them fluids, you give them benzodiazepine, you are okay. But sometimes you think of it. In the scenarios of novel psychoactive, I want you to be careful of using these drugs. Because as I said, the mechanism of this, what happens is not very entirely understood, and the adulteration is there. Adding active agents who work on receptors in the brain and dopaminergic receptors and stuff, you might add injury to you might add to the problem. So I'll be a bit careful of using these drugs. In severe cases, you might want to intubate and ventilate this patient. So finally, I will finish with my experience. I was working in Manchester, UK, and we have Parklife Festival with 400,000 attendee over a weekend of Saturday and Sunday. And the year before I started working there, there was one fatality. It was not purely drug related, but contributed by drug, ended up in a fight, and somebody killed the other. Anyway, so on my year, we've prepared, we've put staff, we've worked with other healthcare agencies and with the police and other authorities. To cut it short, at around 2 p.m., we start to get receiving patients from the festivals. Most of them, your bog standard novel psychoactives, alcohol, vomiting, etc. And then we got a call about patients who very blue and unstable. So she's on 15 liters of oxygen and she remained blue. So we've received her, we looked at her, we've done the ABG, we've diagnosed her methylhemoglobinemia. We started the treatment and given her methylene blue. While we're doing that, we got a call about a male that's coming, and then another female, and then another female. The last one, which I'm interested to tell you about, is a 26 years old, previously fit and healthy. Just gonna go a step back. So while we are treating the second or third patient, the news start to come that vendors are selling golden shot. That's the golden shot. And it is labeled as a golden shot. So you're in a festival and you're happy and dancing and somebody sell you a golden shot, you would think that's an alcohol, that's vodka, that's a shot. A shot mean in the West is a shot, alcohol shot. So you give your £5 or $5 or 5 liras, they use like £5, open, drink, throw it away. And it turned to be not to be alcohol, it turned to be amine nitrate. They brought us the bottle. So this girl came to us in a pericardiac arrest. GCS of 3, severely hypotensive, feeble pulse. So because we knew the story, we prepared the methylene blue before she came. So as soon as she came, she had the line, We just given her the first dose. We've done the ABG. Methemoglobin level is 90.6%. As far as I know, maybe one of my colleagues, experts here, can contradict me. I think this is the second ever recorded for a patient to survive. The first was 93%. If you look at her ECG, this is a young, 26 years old. Look at the depression in the lateral leads. And trust me when I say, this is taken about 20 minutes after we started the treatment. The first one, that's not the proper ECG, that was from the monitor. The first one was much worse than that. But I was in a state of probably, my ECG would have been worse, so I could not get myself to print it out. So she was almost dead. If you look at her lactate, it was 20, her pH went to 6.88. Anyway, so we managed her with methylene blue, we got her better, we got her to HDU, and 2 days later she was discharged. And there was a big, as you can see here, it made the national news in UK that vendors were selling poppers, which is amine nitrate, which is, it gives you the dissociative effect. So the bottom line is the festival party drugs in growing. Don't be panicky when you see a patient who's coming to your hospital taking novel psychoactives, either in party, nightclub, or whatever. Classify them as you see them. You don't know what the drug is. That's not a big problem. Supportive care is the mainstay of the treatment, and be aware of the hyperthermia. And thank you very, very much for letting me having the extra 7 minutes. Thank you. And drugs we can talk later.
Thank you very much, Dr. Ashraf, for a nice speech. To me, myself, I think this is a disaster.
My talk was a disaster?
No. First of all, drug use is a disaster. It advanced common, especially even in our country, especially in New Year celebration and birthday celebration, even after some competition like football team. Yes, and it is common advancing among the young people, even in some adolescents. I am wondering, while you are preparing your presentation, what does the authorities think about the precaution and prevention of this disaster? Because this is a voluntary intoxication, not abuse, not suicide, but voluntary intoxications. So it is coming. We have many, even in Turkey, I said. What does the authority think about the precaution and the prevention?
It's a very important question, and it is a difficult question, and different countries have different rules based on cultural, traditionals, and religious beliefs and religious rule. For example, in the Middle East, you have anything, in Arab countries, you have anything with drugs, alcohol is banned, so this is one shop stop, banned. You can't use any of this. And when you're talking about Europe, when you're talking about America, the debate is big. And there is points for every side of the debate. Some people said legalize drugs, legalize cannabinoids, and you can see the point at some time, at some levels. And some people say, well, you ban everything and you criminalize everything and you make it all class A or class B, depending on the effect. There's a lot for us to learn. As Dr. Brent said before, it's a growing, the addiction and drug of abuse is a growing field. In Europe, for example, there is a lot of collective responses. There is monitoring. There is the European Union has had the last probably 6 to 10 years, a proactive approach to this. But we're still nowhere near where we are, and the debate will continue for probably as long as I'm going to practice medicine. It's not an easy debate. Do you legalize and what you don't legalize? If you can look at it, I'm going to throw this fact to you: the deaths that we're getting from novel psychoactive, the deaths we got from cocaine before or the other, is nowhere near the deaths we're getting now. So does that mean that you legalize cocaine? I don't know.
Thank you for excellent presentation, sir. I have one question about methylhemoglobin case. What was the real reason for this methylhemoglobinemia? I cannot catch the real reason.
Okay, I'm really sorry. Probably I skipped one. Can you get the slide back up? It's amine nitrate. Amine nitrate. It is. It's a drug of abuse. Last slide, please. It's a drug of abuse. It has a dissociative effect. It is used a lot in the homosexual community, but it's also used a lot in the gay club scene, but it's also used in festivals. Now, the people who run the festival was having stalls. We're having stalls. They sell the shot as. Can you give me the one before the last? So, and they use it as alcohol, as a shot. So people who drank it, they think it's alcohol, but it was amine nitrate.
The alcohol that was, you thought that it's the labeled alcohol or off-labeled?
It was not alcohol. It was mistake. It's a bad marketing. You market something. Sorry, the one before. So you see, liquid gold, and it is shot. And the other side says shot. So people drank, thought it's alcohol.
Okay, I understood.
But it's not alcohol. It was, I don't know, deliberate or otherwise, that they did it this way. And people drank it, and they thought it's alcohol, and ended up in hospital.
Thank you.
Thank you very much.
Thank you again for that wonderful talk. Thank you. He is a physician at Maimonides Medical Center in Brooklyn, New York. Welcome.
Thank you. All right, good morning, everyone. Thank you for the introduction. Today, I would like to talk about alcohol withdrawal. I have no conflict of interest. The goals of this talk is to talk about the pathophysiology and the presentation of alcohol withdrawal syndrome, and I would like to talk about the treatment modalities and the goals of treatment. Just a little bit of historical perspective. Alcohol withdrawal has been described as early as Pliny the Elder, who wrote the first encyclopedia in like the year 77. And then it was later described the treatment by Sir William Osler in the late 1800s. In the early 1900s in the US, alcohol withdrawal and alcohol use was a very big problem. In New York City, there was 5 admissions per every 1,000 residents. Similarly in Boston, 10% of admission at the Boston City Hospital were for alcohol use-related problem. And these patients had a 52% mortality at that time. Currently, ethanol is still a big problem worldwide. We have around 4% of all deaths worldwide that can be attributable to ethanol. The lifetime risk for alcohol use disorder is greater than 20%, and this is a little bit higher in males than females. Currently in the States, the alcohol-related complications constitute 21% of all ICU admissions. 8% of all general admissions to any hospital will develop alcohol withdrawal syndrome, and around 31% of trauma patients will develop alcohol withdrawal. And again, in this subset of patients, they have a 3-fold higher mortality than any other trauma patient. So what is alcohol withdrawal? By definition, it's a neurological disorder. It is a progressively worsening symptoms caused by the effect of chronic ethanol use, and it's often exacerbated by the clinical manifestation of alcoholism. Clinical manifestation, we can think of mild, moderate, severe. Mild, we have anorexia, anxiety, emotional liability, insomnia, irritability, and then the symptoms would be diaphoresis, hypertension, headaches, tachycardia, a little bit of fine tremor. Moderate, we get all the symptoms above, plus agitation and a coarse tremor. Severe, we have CNS involvement, we have confusion, delirium, seizures, hallucinations, and lastly, hyperthermia, which is a significant factor for morbidity. Why does it happen? With chronic ethanol use, we have two main receptors that are often involved. The first one is the GABA receptor. With chronic ethanol use, we have downregulation of the GABA receptor and desensitization. So we're less sensitive to the sedative effect of GABA. In addition, alcohol binds to the glycine part of the NMDA receptor, which makes it less functional. So in compensation, we have upregulation of NMDA, which is excitatory. So in alcohol withdrawal, the net result is decreasing GABA and less sensation of GABA, which is the sedative, and we have an upregulation of excitatory NMDA. The risk factors for alcohol withdrawal is a prior history of alcohol withdrawal syndrome or delirium tremens or strong family of history. And again, this is a little bit challenging in the emergency department because we often do not have a history of alcohol use. And this is really important for us ED providers or any provider when you see a patient to screen for alcohol use disorder. There are a couple tools that we can use. We can use the CAGE questionnaire, which is a 4-item questions that we can ask our patient and try to screen for alcohol use disorder. And then the Audit-C is another small questionnaire that we can use to screen for alcohol use and any other substance use. In addition, if you identify the patient and you're admitting your patient for any different reason besides alcohol, and they happen to have an alcohol use disorder, there's a tool, prediction of alcohol withdrawal severity scale, that can predict with a good accuracy whether our patient is at risk for developing complicated withdrawal and whether they need a higher level of care, such as an ICU. So what is the timeline? Usually, historically, we can think of alcohol withdrawal as lasting between around like 3 to 5 days. When we think about it, and we'll talk more about it in future slides, we can think of either early versus late, and we can think of complicated versus uncomplicated alcohol withdrawal. So let's start with the early uncomplicated withdrawal. It's called alcohol tremulousness. This happens around 6 hours after the last drink. Patients often have an autonomic hyperactivity. They complain of tachycardia, a little bit of hypertension, psychomotor agitation, maybe some fine tremor. This is often treated as an outpatient by the patient themselves. They just have, you might have heard the term medicinal beer. They just have a beer and then the symptoms can resolve. And we often do not see, these patients do not present to the emergency department. The second syndrome to look for is the alcohol hallucinosis. This happens in around 25% of patients with alcohol withdrawal. The main thing is patients have transient hallucinations. These can last a day, a couple days, and it can be reported up to 2 weeks. The hallmark is tactile hallucinations. Patients describe formications, which is the sensation of ants crawling under the skin. And then the other hallucination is the visual hallucination. You might have heard the term pink elephant. This is patient just described abnormal hallucination. And it's really interesting in the literature how the pink elephant became the dominant animal in the visual hallucinations. Like back in the 1800s, there were the green elephant, the feathery hippopotamus, and then sea snakes in boots. But then somehow in the early 1900s, just the pink elephant became the dominant elephant of hallucination. The hallmark of alcohol hallucinosis is a normal mental, a clear sensorium, and a normal vital signs plus hallucinations. Interestingly, there is no association with the development of delirium tremens, or maybe just the data is still lacking. The next syndrome to recognize is alcohol withdrawal seizure. This is often just a single seizure. In around 3% of patients, patients will go on to develop multiple seizures. It can be the first presenting sign of alcohol withdrawal. And interestingly, a third of these patients will go on to develop delirium tremens. And again, anytime you have a seizure with an elevated ethanol level, this is often a concerning sign or could predict a worse withdrawal. And the last thing to recognize is delirium tremens. This is the most dreaded complication and has the highest morbidity and mortality. It tends to happen 2 to 3 days after cessation of drinking. And the hallmark is autonomic instability, hypertension, tachycardia, and all this hyperreflexia, agitation, plus we have an altered mental status, we have change in cognition, and then we have development of perceptual disturbances that we cannot account for by trauma, infection, or any other organic disease. So how do we monitor? How do we risk stratify these patients beside the history? There are two tools that we can use. The CIWA, Clinical Institute Withdrawal Assessment for Alcohol. This is a tool that is a little bit subjective. It depends on patient interaction. Patient has to tell us what they're feeling, how they're feeling. They're nauseous, they're anxious. It takes a little bit more time than the second one, and it depends on patient interaction. So one of the challenges is we cannot use it if the patient is acutely agitated or very sedated. It just needs patient interaction with it. The next one is the Richmond Agitation Sedation Scale. This is a tool often used in the ICU for sedation of patient and can be used for alcohol. It's a little bit faster and does not require a cooperative patient and may be helpful in patients who are not really cooperative with our questioning or exam. So let's talk a little bit about management. How do we manage these patients? I think the most importantly is just treat the medical condition. It seems that a big subset of our patients stop drinking because they have another concurring medical problem. They have pancreatitis, they have sepsis, pneumonia, any other trauma, right? People just seems to stop because of medical problem. And it's really important to recognize this problem and treat it appropriately, as alcohol withdrawal could be the secondary aspect of this primary medical problem. And I always look for trauma, CNS trauma, falls. Patients may not be able to provide history of trauma, as they can have blackouts or they can just pass out, and just always screen for that and look for the primary cause why your patient is in the hospital. So early stages, we talked about it, alcoholic tremulousness. This happens early, it's often uncomplicated. Patients often treat themselves at home. They drink a beer, they have another serving of liquor. When they present to the emergency department, not all these patients needs to be admitted. If your patient has a CIWA scale less than 8, which constitutes a mild to moderate withdrawal, and they have no history of complicated withdrawals, such as no history of seizures, DTs, and they have no medical comorbidities, no psychiatric morbidities, it may be safe to treat these patients as an outpatient and then link them to healthcare as an outpatient. How do we manage seizure? We mentioned that it's often a single seizure and it's often limited. And again, only 3% will go on to develop multiple seizures. Lorazepam 2 milligram IM have been studied in a series, and it looks like it reduced the risk of recurrent seizure and need for hospital admission. And interestingly, the effect on the progression for alcohol withdrawal is still unknown. There is no roles for anti-epileptic in alcohol withdrawal seizure unless your patient has a primary seizure disorder from a resulting trauma or any other causes. So the mainstay of treatment is benzodiazepine and sedatives. Since the hallmark of alcohol withdrawal is agitation, there's been a historical interest in using sedatives. And this study is from 1969 by Kaim et al. They randomized patients with alcohol withdrawal to multiple treatment modalities. And some of the take-homes here is chlordiazepoxide, which is a benzodiazepine, did reduce the incidence of delirium tremens and seizures. And interestingly, chlorpromazine, which is an antipsychotic, did increase the risk of seizure. And this speaks for the fact that antipsychotics may lower the seizure threshold and put your patient at a higher risk of seizure. This is why oral therapy with chlordiazepoxide has been favored historically, and this is the medication that a lot of providers have most experience with. So in the case that we need faster onset of sedation, or the patient is unable to tolerate oral, we should think of using parenteral benzodiazepines. And there's a couple options that we can use. The first one is midazolam. As you can see in this graph, it has a quick on and a quick off. You can sedate your patient quickly, put an IV, do a CAT scan, do whatever test you need to, and then you can reassess your patient quickly. The second, which is a little bit preferred, is diazepam. It has a quick on and then has a longer off because diazepam has active metabolites. And we know that alcohol withdrawal, you expect treatment to last, a couple days if you're admitting them to the hospital. Using an agent with an active metabolites will give you some protection. It might reduce the need for repeated dosing for diazepam. Again, because the active metabolites are just active and could be protective against alcohol. Lorazepam is an interesting agent. One of the challenges with lorazepam, it has a slightly delayed onset of action. It takes around 20 minutes for sedation to kick in. And you can imagine in a busy emergency department with very anxious ED providers, this could be a challenge if you overstack dosing and you end up with an overly sedated patient at the end. Another challenge of lorazepam, it does not have active metabolites. So in a healthy patient with a healthy liver, you might need to frequently redose lorazepam. This could be helpful, however, in elderly patients and patients with liver disease, where the elimination of benzodiazepine is delayed, and you might want to use an agent that doesn't have active metabolites, such as lorazepam. And if your hospital carries it, oxazepam might be another agent that you can use that doesn't have active metabolites. Treatment end goals, the goal is to have a sedated patient is breathing spontaneously and have a normal vital signs. Although having normal vital signs is not a main end goal, but it's really important to try to achieve it. And it's always good to think, if you don't have a normal vital signs, this could be a cue that we're missing a primary medical problem. And look for sepsis that we're missing, look for hemorrhagic shock or anemia or stuff like that. Lastly, we can monitor treatment with a CIWA scale. So a CIWA less than 8 is a CIWA 8 to 10 is a goal that we try to aim for. And if your patient is overly sedated, think of using the RASS to monitor sedation and need for further treatment. So how do we give benzodiazepines? There's two types. There's the fixed treatment. You give benzo around the clock, or you can do symptom trigger therapy. Symptom trigger therapy seems to decrease the amount of benzodiazepine, seems to decrease the amount of time the patient stays in the hospital. And interestingly, it has no increase in withdrawal seizures or adverse events. In a few subset of patients, we have benzodiazepine with resistant withdrawal. These patients take a huge amount of diazepam, probably 200, 400 milligrams without any clinical improvement. There's two other things we can use. Phenobarbital. Phenobarbs opens the GABA channels regardless whether we have GABA or not, and it could be helpful. Phenobarb, it take around 20 to 40 minutes for the clinical onset of action, so just be patient and avoid dose stacking because you might end up with an overly sedated patient. Second agent is propofol, and one of the benefits of propofol, it works on the NMDA receptor as well, so you get the added benefit of the NMDA. One of the challenges, it has a narrow therapeutic index, can lead to metabolic disorders if given for a long time, and your patient might need to be intubated and upgraded to a critical care setting. Some of the adjuncts, and again, the data for these agents is convincing for some and not for others. Baclofen have been studied, and again, rigorous studies are still pending. Carbamazepine in animal studies did increase GABA level in animals, but then again, translation to clinical medicine in acute withdrawal is still pending. Similarly, valproic acid has limited efficacy, but then some good signals. Gabapentin have been studied in high doses and low doses, and it could be used as an adjunct. Again, good studies are needed. And the last category is sympatholytics, such as clonidine, dexmedetomidine. These agents tend to normalize the vital signs. You can reach your end goals as far as sedation, tachycardia, hypertension. However, one of the challenges is they don't work on GABA or NMDA channels, so you may not be treating the underlying pathophysiology of withdrawal, and this puts you at a risk of under-administering benzodiazepines. And interestingly, in the series that we know, it did not change the duration of treatment. Think of nutritional support. A lot of chronic users, alcohol users, are often deficient in multiple vitamins. They have unhealthy diets. Thiamine is a water-soluble, it's B1 vitamin that is often deficient. It could be very consequential, as it can lead to Wernicke, Korsakoff, and beriberi. One caveat, chronic users of ethanol and patients acutely intoxicated have decreased oral absorption, so you might want to replete parenterally, give IM or IV when feasible. Magnesium has no effect on the duration of withdrawal. However, a lot of our patients are hypomagnesiemic, and it's good to replace if needed. Similarly, think of other vitamins, folic acid, B6, all the other B vitamins. Patients with chronic alcohol use are often volume depleted, so just volume deficient, so just give fluid back, and similar as dextrose. And a nice new case series, patients with alcohol use have been noted to have vitamin C deficiency. And the title is really nice, Add an Orange to the Banana Bag, if you guys use a banana bag. Last and most importantly, this is always a good opportunity to catch our patient and link them to healthcare. Think of linking to detox centers, using rehabilitation, and think of using social worker as if your hospital emergency department has the resources for that. Thank you very much.
Thank you for that very comprehensive overview of alcohol withdrawal. Any questions from the audience?
Thanks for your nice presentation.
Thank you.
We usually give benzos for the elderly patients, like half dose of benzos. How about for the alcohol withdrawal? Is there any exact amount of benzos for the alcohol withdrawal, like half dose, like elderly patient?
So if they don't have any history of liver disease, you can just treat as you would do in a healthy patient. In my hospital, we use chlorodiazepoxide aliquot of 25 to 50 milligram, and then we just keep on adding on. As far as parenteral, you can use doses of, we use 10 milligram of midazolam, and we keep on adding. Similar with diazepam, you add 10, and then depending on your patient, you can either think of adding aliquots of 10 or doubling the dose. Again, the caution is a known history of liver cirrhosis, liver disease. These patients have delayed metabolism and elimination, so you might end up with prolonged sedation, and elderly. The older the patient are, the lower the elimination of benzos are.
If you don't mind, I have another question for the phenobarbital. And is phenobarbital over the benzos for the management of the alcohol withdrawal? Because it's effective as benzos, I think.
Right.
We don't use in the emergency department, usually we use benzos, but phenobarbital is effective as benzos, I think. I don't know exactly how to use it, because it's not our practice.
Yeah, I agree. I mean, it seems to be as effective or potentially a little bit more effective, because it just tends to open the GABA channel more reliably than benzodiazepine, and just opens it regardless if you have GABA or not, and opens it for a longer duration, because like the benzos just increase the frequency of it opening. There's a couple ways to do it. In my hospital, and a lot of providers use phenobarbital as second line because it has a risk for oversedation and respiratory depression. And what we do is we give aliquot of 65 milligram of benzodiazepine, and then you up titrate every 30 minutes. There's a series, I think, done in the late 90s where they used seizure dose of phenobarbital. They gave up to 1 gram of phenobarbital earlier on, and the patient at that time did not receive an benzo. They just walk into the emergency department, you identify alcohol withdrawal, you give them 1 gram of phenobarbital, no benzodiazepine, and then they looked at them. But I think the majority, a lot of the providers add phenobarbital on top of benzodiazepine if benzos fail.
Other questions from the audience? All right, well, I'll ask a very basic question. So you mentioned many patients who have mild withdrawal may treat themselves. They have their beer on their own or take a shot or what have you on their own. Why not give IV ethanol for these patients who are in alcohol withdrawal?
Yeah, I agree. I mean, it seems to be the easiest antidote. The problem is, how do we titrate for ethanol? And then I can't imagine our nurses being very happy with intoxicated patients, drinking beers. In my in the hospital where I did residency, trauma patients, when they come in, I mean, you could order a beer every 8 hours, but it seems just difficult to titrate. And we have more easier agents that we can use parenterally and know how much we're getting, and we're just more comfortable with it titrating.
Any additional questions? All right, well, I would like to thank Drs. Morgan, Dr. Kamour, and Dr. Harmouche for this wonderful forum on drugs of abuse and withdrawal.
We're going to present, or we're going to begin our oral research presentations. And there's a slight change to the program. So our first presenter is going to present remotely. So this is Rita Farah, and the presentation is coming from Beirut?
Yes,
Okay.
so Rita Farah is in the Ministry of Health in Lebanon. And she couldn't come here, but since I'm an author as well, we're able to just do it
Yes.
by Zoom.
So Rita, if you can hear us, you can begin.
Sound?
Hi, hello everybody. I can start, right?
Yes.
Hello everybody. I'm going to present the chemical exposure surveillance data for the year 2019. So the chemical incident or chemical surveillance, exposure surveillance was launched in February 2018 by the Epidemiological Surveillance Program at the Ministry of Public Health. So primarily the objective was to build national capabilities to detect and respond to chemical exposure. And we needed to understand the profile of chemical exposure in Lebanon, meaning measure incidence, describe product exposure, as well as outcomes. So in 2019, we had 338 cases reported by 30 hospitals, mainly by the emergency department, of which we had 11 clusters, 2 cases of deaths, one from carbon monoxide accident, and one was intentional, a suicide using pesticides. The mean age of chemical exposure incidents was 26 years, plus minus 6 years. The most frequent chemical agent types were, number one, were pharmaceutical products. 35% of chemical incidents, pharmaceutical products were involved. The top class was benzodiazepine, followed by antidepressant and antipsychotics. As a single agent, paracetamol was the number one agent among pharmaceutical products. Ranking second, we had the non-pharmaceutical agent types, meaning the cleaning household products were involved with 32% and 9% with pesticides. When we come to the reason, 43% were intentional, and half of these intentional accidents were suicide or suicide attempts, and 39% remained were unintentional, and the rest remained unspecified. As we come to the place, 46%, the majority of the cases occurred at home, 20% at school, and 9% were occupational exposure. As a conclusion, after almost 2 years of chemical incident surveillance, we can say that it is well established in Lebanon, and now we have a better understanding of national chemical profile, and such information will guide needed health education and awareness for prevention. We are preparing for brochures for different topics, including carbon monoxide, snake bites, and toxic plants. Thank you so much.
Thank you, Dr. Afra.
Thank you very much. Do we have any questions? We have 1 minute for questions from the audience.
We have one question.
As a place, the percentage of school is very high, 20%, 1/5 of all exposures. Are there physical exams in schools in Lebanon? Or unintentionally?
Okay, so that I can't answer that question unless Dr. Farah will answer that. So I can get back to you with that because she has the data for that. So this is a passive reporting from 30 hospitals that volunteered and participated in the project, and they just ask where it happened. But that's a good question too. We could probably have that data, and I can share that with you. Thank you.
Okay, thank you very much. So our next presenter, so now we're back onto the regular program. Our next presenter is inaccurately listed as myself, but Dr. Lina Amin, the manager of the Qatar Poison Center, is going to present pharmacist-led management of home poisonings in Qatar. quality assessment study.
Good afternoon, everyone. All right, good afternoon, everyone. So the first study that I'll be sharing with you is Pharmacist-Led Management of Home Poisonings in Qatar, a quality assessment study. I have nothing to disclose. So as all of you know, poisonings can obviously lead to significant morbidity and mortality, but actually the majority of poison exposures that we encounter don't even require management in a healthcare setting. At the Qatar Poison Center, we manage the nationwide helpline for poison management, where we provide consults through the phone to both the public and to healthcare providers. And the aim of this study was to specifically look at the cases that we independently manage as SPIs, or specialists in poison information, or pharmacists, that we manage at home without referral to a healthcare facility. So we looked at data collected, or case exposures collected, from December 2018 to March 2019. We specifically looked at human exposures that came from non-healthcare facilities. So this would be residences, schools, public areas, essentially calls from the public directly made to the poison center. And then we looked at, we collected descriptive data for these cases, and also looked at the assessment of the toxicity that was made by the specialist in poison information and the medical outcome, both at the time of the call and then on follow-up. So 33% of the cases were, 33% of the cases that we looked at were made from non-healthcare facilities. The Poison Center recommended home management for 73%, so the majority of those cases, and only 27% were referred to a healthcare facility. All of the, or most of the cases that were managed at home, or 89%, were assessed as either non-toxic or subtoxic exposures based on triage amounts, symptoms, based on guidelines and protocols that we have at the Poison Center, and 11% were assessed as potentially toxic. All of the cases that were managed at home, so 100% of the cases that we kept at home, that we recommended the patient that they don't need to go to the hospital, all of those had either no or very minimal effects on follow-up. So in conclusion, the QPC pharmacists, or the specialists in poison information, can safely prevent unnecessary visits to the emergency department by managing those patients at home. The patients who were managed at home had no adverse outcomes, and none of those patients actually required further referral to a healthcare facility after the initial management. And this demonstrates that this service, the Poison Center existence or purpose in Qatar, can actually lessen the burden on emergency departments by preventing unnecessary visits to the hospital.
Okay, thank you. Any questions?
Toxins were reported in these cases of patients that were successfully managed at home?
Yeah. Most of our home exposures are related to household detergents and cleaners. And then that's our that's our number one category, followed by medications, and then followed by other substances.
Thank you.
Sure. Else? No? Okay. And hello again. The surgical one, this says surgical. Yes, great. Okay. So the second study that I'll share with you is titled Frequency of Poison Center Cases Involving Surgical Issues, 1-Year Retrospective Study. I have nothing to disclose. That has not changed. Okay, so in my work as a SPI, as a pharmacist at the Poison Center, it's very, very infrequent that we involve, or that I have to involve or consult the surgical service. However, there are a few exposures that do benefit, or that may benefit from consult of our colleague surgeons. And this study specifically looked at the frequency with which this occurs. So how often do we come across cases at the Poison Center that we would need to consult surgical subspecialties? So this again was a retrospective study. We looked at cases from actually the first year of study, or the first year of operation in the Poison Center. So sorry, the first bullet point's incorrect. And we looked at the SPI, and the medical toxicologist went through all the cases that we received during our first year of operation and looked at which of those could have benefited or we did consult the surgery team. So those cases involved foreign body ingestions, caustic exposures, animal bites and stings, and all cases that involved or could have involved compartment syndrome. So the results that we found were that most of the cases, the majority of the cases, 54.5% were related to caustic exposures or ingestions, followed by foreign body ingestions, animal bites, and finally burns. For foreign body ingestions, the majority of those were related to button batteries, followed by high-powered magnets, and then we had water beads and some other ingestions that were involved. In conclusion, we identified 198 cases that were managed by a poison center that would have required or involved issues with surgical relevance. Poison centers don't usually consult the surgery team, and however, regular consultation with surgeons in certain relevant cases would improve patient management, would decrease the time needed to emergent surgical intervention, and would be both informational to the surgical team and would help establish kind of a pathway of communication between the poison center and the surgery team for all future cases. Any questions?
Thank you. Any questions? Thank you very much. Thank you.
The next one.
No.
Okay.
Our next presenter is Dr. Bruno Bergarben, and he will be.
So, good afternoon, everybody. As you know, acetaminophen is the most prescribed drug worldwide, but there are dangers related to repeated supratherapeutic ingestion, and this is still an issue because it is poorly known by the general population. So our objectives with this study were to report a case series of acetaminophen-positive patients resulting from repeated supratherapeutic ingestion admitted to our ICU in Paris, and to analyze the risk factors, the observed complications, and the final outcome of the patients. We conducted a retrospective single-center observational study on about 10 years, including all acetaminophen poisoned patients from repeated supratherapeutic ingestions admitted to the ICU. We defined this situation by the ingestion of a supratherapeutic dosage. That means more than 1 gram 4 times per day, with a minimum of 6-hour intervals between 2 successive oral intakes. Of course, in the absence of self-harm or suicidal attempt as assessed by a psychiatry consultation. So we were able to identify 22 patients, mainly women, median age 35 years. The presumed ingested dose was 15 grams during 24 hours. Patients were admitted to the hospital with a median delay of 48 hours after the first ingested dose, and generally they were admitted due to abdominal pain and vomiting. On admission, the usual biological parameters were in the normal ranges, except transaminases, which were elevated, and with a slight decrease in prothrombin index to 61%. Of course, as expected, serum acetaminophen concentration was almost normal, at least very low. So we identify the presence of individual vulnerability in 7 patients who were chronic alcoholics. None of our patients received cytochrome inducer drugs or were anorexic. Of course, all the patients were immediately treated with N-acetylcysteine as soon as the diagnosis was suspected. Unfortunately, despite the treatment, severe complications occurred. Acute liver injury, 88%, metabolic acidosis, 27%, liver failure, 23%, acute renal failure 23%, and deaths in 3 patients. These 3 patients were not transplanted because they arrived with a delay to the hospital and in the presence of multi-organ failure, requiring mechanical ventilation and high-dose norepinephrine infusion, and these were contraindications for liver transplantation. So our series confirm, of course, probably you know that chronic or staggered intoxication with acetaminophen is much more severe than voluntary ingestion. You see here this historical series comparing both situations. You see that in voluntary intoxications, if the patients ingested a median dose of 20 grams, so in one ingestion, and the death rate was 2%. While in accidental situations, they ingested 12 grams, so almost half of the dose, but the mortality rate was 19%. So accidental acetaminophen ingestion is much more severe, as confirmed in our series, with 3 deaths among 22 patients. So acetaminophen repeated accidental or supratherapeutic ingestion may result in severe liver toxicity, life-threatening presentations, and high-rate fatality. And this is relatively easily evitable by public information to limit misuses. And recently in France, about 2 months ago, the health authorities decided to stop the possibility of the pharmacist to deliver acetaminophen without a prescription. So now acetaminophen prescription is mandatory in France. Thank you.
Experience with therapeutic excess of paracetamol. Do you think, or otherwise, that the morbidity and mortality associated with it is more than that of acute because of ongoing consumption of glutathione, or that just a theoretical proposal has no reality in it?
That's a good question. I don't know exactly the mechanism. I'm not sure even if there is any knowledge about the exact reason why this supratherapeutic overdose with acetaminophen is more severe than self-harm ingestion of a huge amount. Probably the fact that you ingest repeatedly acetaminophen will consume all your protective antioxidant in the cell, and you will not be able to regenerate it rapidly, even if you are treated with N-acetylcysteine on time. Because many of these patients receive relatively rapidly acetaminophen, sometimes less than 2 days after the first ingestion, but despite this, they developed acute liver failure.
Thank you very much. Ahmed Al-Abri is going to discuss the utility of salicylate levels for all cases of paracetamol overdose.
Hello. Yeah. Hello, everybody. Thank you for your introduction, Dr. Ajay. Welcome, everybody, to my presentation. I'm actually going to present my research, which is about the utility of sending aspirin in all cases who are coming with paracetamol overdose. So there is a common practice among emergency physicians. They are sending salicylate for any cases who's coming with paracetamol overdose. Although there were a lot of study came later, it showed that the routine testing for salicylate may not be required for fully conscious patient who is denying any history of aspirin intake and who showed no clinical features of salicylate toxicity. Now, what about Oman? That's why, because there were no much study in Oman, so we create our own question. What is the utility of sending salicylate level for all cases with paracetamol overdose who present to Royal Hospital, which is a tertiary care hospital in Oman, from 2007 to 2017? So we did a retrospective chart review study during this period from 2007 to 2017, and this is the data collection sheet. We found that total of 338 patients presented with paracetamol overdose. The emergency physician, they were divided among those cases. So in 189, actually, the emergency physician, they sent the salicylate for them, while in 149, salicylate level was not sent. Among those 189, salicylate was positive in 6 cases. Let's go through them one by one. So in 4 cases, there were very clear indication for salicylate to be sent. Actually, because 2 of them, they gave history of aspirin ingestion with the paracetamol. And one of them, he showed that a clinical picture, he was altered mental status, which is also, you need to screen for other toxicity, not only paracetamol in this case. And one patient, she showed that she's having a metabolic acidosis and respiratory alkalosis, which is also, again, one of the clinical features of the salicylate ingestion. The 5th case gave only abdominal pain. Now, this patient presented only a few hours after the paracetamol ingestion, and it was not clear that only paracetamol was ingested. So the emergency physician, that's why he go ahead and send the salicylate for this patient, and actually it came positive. The only patient where there were no clear indication to send anything other than paracetamol was the last one, because he denied any history of intake other than paracetamol. He was fully conscious, no clinical picture, and the salicylate came positive for this patient. Among those 6 patients, only supportive management was given for them, i.e. there was no dialysis, no sodium bicarb was needed for them. Now let's go back to those cases where salicylate was not sent to them. 149 cases, salicylate was not sent. So in those cases, none of them came back to ER later if they got discharged with a salicylate-related toxicity. And also, if they got admitted, if salicylate was sent, none of them also salicylate came to be high for those cases. What about the last case, the 6th case? 1 patient was missed. Now, this case was discussed with a toxicologist and discussed with a statistician, and from their point of view, it's insignificant to miss 1 case out of 338 cases. So, in general, our research looks like it's going in favor of the latest research that there is no need to send salicylate routinely for all cases who are coming with paracetamol overdose. Thank you.
Thank you very much. Any questions? Yes.
Thank you for your presentation. On a hindsight, why do you think that there's something else in the presentation of that case? That it was
the last one?
Yeah, that would have triggered you to test for salicylate at the time presentation? Because despite this, as you said, the statisticians and the toxicologists said it's not significant, but the life worth saving is important. I agree with the notion that you don't need to test salicylate unless you have a clinical history or whatever suggests otherwise. But I'm interested to know if, on hindsight, would you have done it in that particular case?
I don't think so, because as I said, only he said, I took the paracetamol, he was fully conscious, no clinical features, that's it. So in this case, if I decided to go salicylate, why don't also I go and investigate also other drugs, like the opioids, other medication, I will do the full screening for toxicity panel. So that will open that door also. Shall we send those investigation or not?
Okay, thank you very much.
Welcome.
Next presentation is going to be evaluation of patients with iron toxicity in the emergency department. Dr. Amin Emektar.
Good afternoon. I'm Dr. Emine. I'm from Ankara Keçiören Training and Research Hospital. The study title of, I am so exciting, by the way, evaluation of patients with iron toxicity in the emergency department. There is no conflict of interest. Acute iron poisoning incident common in our country, in Turkey. In this study, we investigated demographic, clinic, and laboratory featured treatment modalities and complication of patients present to our emergency department with iron toxicity. This is a retrospective study. We enrolled the patient aged 18 years and older, admitted to our emergency department last 5 years who had been diagnosed with iron toxicity. Patients with missing medical data were excluded. We recorded the demographic information, vital signs, amount of iron intake, additional drugs, blood iron levels, hospital outcome, admission and during hospital stay. We divided the patients two groups by the amount of iron intake. Doses below 20 milligram kilogram were considered as non-toxic. About 21 milligram kilogram were considered toxic. 61 patients were included in the study. 45 patients were female, and median age of the study population was 32. About half of the patients had taken additional medication. Most common group were analgesic. The mean amount of elementary iron taken by the patients was 1,000 milligram, and 4th-hour iron level was 246 milligram. None of the patients died. Evaluate the blood iron level and amount of iron. There was weak, statistically significant positive correlation between the amount of iron intake and blood iron level. Comparison of blood parameters at admission and during the follow-up 4 hours showed the significant decrease in hemoglobin, VBC, platelet, and creatine levels, and significant increase in the INR level during the follow-up compared to admission. No significant difference was the other blood parameters. Also, no significant difference was found between the toxic and non-toxic group, all blood parameters. In this study, we reached two findings. Firstly, although about half of our patients had taken toxic dose iron, there was a weak correlation between the amount of iron intake and blood iron level. About half of our patients had taken toxic dose of iron. Toxicity was mild, majority of patients. Secondly, we detected decreased some laboratory parameters, but we don't consider as clinically meaningful. Also, we didn't find any difference in renal and hepatic function test follow-up in the toxic or non-toxic group. We also found increase the INR level. We believe may indicate tissue affection at cellular level without any clinical affection. Thank you.
Wondering if it has to do with the fact that you said the most common co-ingestion was analgesics?
Yes. Maybe INR increase related to analgesic. Maybe.
Because I'm just I'm sorry. I was just wondering if maybe that would have been, you know, an NSAID or something.
NSAID. All of
The analgesics, were they non-steroidals?
No paracetamol. All drugs is NSAID.
Okay, okay, thank you.
Good afternoon, everyone. So the third study and the last study that I'll be sharing with you is looking at the incidence of fipronil-related exposures that we've had reported to the Qatar Poison Center. So again, I have nothing to disclose. So fipronil is actually an insecticide that is commonly used in Qatar. We've had a few exposures reported to our center over the past year. It's a newish insecticide. It actually works by inhibiting GABA-A chloride channels in insects at a higher affinity than it does in mammals and in humans. So technically should have, or does have, lesser toxicity to humans than it does to insects. However, there's not a lot of data related to exposures to fipronil. There have been very few case reports in the literature. There's one case series. But other than that, there's not a lot of data available regarding its toxicity. And the aim of this study was to look at the acute clinical effects associated with fipronil exposures in Qatar. So we looked at the cases received at our center, and we collected information related to the exposures that include patient age, the route of exposure, how critical the case was, and the clinical effects related after the exposure and that were detected on follow-up. And additional descriptive data was also collected and analyzed. So we had a total of 19 cases reported to the Qatar Poison Center. The median age for all the patients that we collected the data on were 2 years, and all of the patients were pediatrics, or less than 12 years of age. The majority of them, 57.9%, had no clinical effect. 42%, however, had a range of effects, from GI effects, those were 31.5%. Some also had neurological symptoms, but those were lesser, those were 10.5%. And the neurosymptoms that most of the patients had did not include seizures. Most of them were mild, like drowsiness, lethargy. And finally, dermal symptoms were also common, or less common at 5.2%. So fipronil exposures are associated with mild clinical effects, including GI and neuro symptoms, based on the data that was reported to the Poison Center. We did follow-ups on all of those patients and determined that none of them progressed to medium or even severe toxicity. However, poison prevention approaches should be widely implemented to educate patients or users or the public about the toxicity or the potential for toxicity with fipronil in Qatar. And actually, a lot of the products, I don't know if I have a picture, a lot of the products that we have that include fipronil are actually don't have enough labeling on them. So this is something that we're working on at the Qatar Poison Center to increase awareness of these products.
Thank you very much. Any questions? Thank you, Dr. Amin.
Okay, thank you.
Presenter from Kuwait could not join us. Our next presenter will discuss hospital mortality due to acute poisonings in Azerbaijan. Dr. Ismail Afandiev.
Thank you, dear colleagues. Thank you for the invitation, opportunity to speak. I represent the Poison Center of Ministry of Health. It's only medical institution in Azerbaijan that is responsible for treatment and prevention of all kinds of poisoning, both in adult and children. There are several departments: ICU, pediatric, dialysis, efferent therapy, hyperbaric oxygenation, laboratory, diagnostic, and poison information unit. The epidemiological data on fatal poisoning in Azerbaijan is very limited, so the aim of the study was to evaluate and analyze the characteristic of hospital mortality due to acute poisoning in Azerbaijan. Investigation was performed on data of poisoned patients admitted to Poison Center in Baku from the 1st January 2009 to 31 January 2019. The total number of PCC admissions was 21,911, and number of deaths was 542. Despite the predominance of female patients admitted to PCC. It's 56.5%. The inverse proportion was observed among fatal poisoning. And in age distribution, the largest was the age group 50-59 years old, 22%. Or then considering the mortality rate in certain age group, there's clear and reliable tendency to increase this indicator with age. So if the age group 15-19 years and 20-29 years, the percentage of mortality was only 1.04%, then in age group over 70 years, the indicator significantly increased to 9.25%, and P, it's less 0.001. As you can see in this chart, the largest share in structure of lethal poisoning belongs to poisoning from corrosive liquids, which 93.7% are vinegar essence, acetic acids. Acetic acids, being 70% organic acids, is available in each grocery shops in Azerbaijan and used for preparing domestic pickles. And it's common xenobiotic for committing suicides. And it caused deaths of patients both from acute renal and hepatic failure developing as a result of blood hemolysis, as well as from exotoxic, hypovolemic, and post-hemorrhagic shock in early first, third day stage of poisoning, and in late complication as gastrointestinal bleeding in 35.3%. The mortality of this nosology was 10.7%. Only the lethality of poisoning by alcohol surrogates exceeds this indicator. However, the total number of hospitalization of these patients was small, only 33 patients. And corrosive, as conclusion, corrosive substances and particular concentrated acetic acids is the main reason of hospital mortality in Azerbaijan. Acute narcotic drug poisonings and toxic gas inhalation poisoning are main reasons of toxicological mortality directly at the site of incident, while hospital mortality of these nosologists was relatively low. To reduce lethality of carbon monoxide poisoning, all rooms with gas appliance must be equipped with CO detectors, as free sale of concentrated acetic acids in the stores should be prohibited. Thank you.
Thank you very much. Any questions from the audience? Yes.
Majority mortality is coming among the patients who get corrosive and corrosive substance. Yeah. But your age, the exposure, the age was between 15 and 59. This is the highest one. As we know, the person who gets corrosive, they are almost young. But in your studies, they are about 16. What do you think about this? Do you think is it suicidal?
Yes, exactly. It's suicidal for last years in our country due to a drop of oil prices, what big bank crisis, and many, especially men who had credits in banks, they cannot pay money for banks and they committed suicide using by acetic acids. So it was the rise of this age group.
And I just have one question to understand. So one of your slides indicated you have 21,911 admissions or deaths. So that means cases or hospital admissions and deaths are 21,000?
Yeah. 21,000 patients with severe poisoning that admitted to ICU department in this period of time, and of this, it's 524. It was death. We not include in this investigation our outpatients.
Okay, thank you.
Thank you.
Any other questions? Thank you very much.
Thank you.
Of therapeutic effect of silibinin in experimental corrosive esophageal burn model by Dr. Sinan Pasli.
Good afternoon, everyone. I am Sinan Pastor from Karadeniz Technical University, Department of Emergency Medicine. I will talk about an experimental study we have made on rats. This study was conducted to investigate the effects of silibinin on corrosive esophageal burn caused by sodium hydroxide. To remember, silibinin is an active substance contained in the seeds of Silybum marianum plant. Due to its high antioxidant and anti-inflammatory effects, it's currently used as an antidotal treatment, as we know, for fungal poisoning containing cyclopeptides and also liver and gallbladder diseases. Its main mechanism is antioxidant effects, preventing lipid peroxidation and protecting the body against glutathione reduction. When we look at our study, we have 4 groups, each consists of 7 rats. The first group and the second group received no burn, and the third and fourth group received 0.2 milliliter, 12.5% sodium hydroxide. Rats were first anesthetized with 50 milligram per kilogram ketamine and 5 milligram per kilogram xylazine. In order to reduce pain, 1 milligram per milliliter paracetamol was given to the rats by drinking water. As a treatment, Group 1 and Group 3 received 1 milliliter normal saline, and Group 2 received 30 milligram per kilogram silibinin intraperitoneally, and Group 4 received the same with Group 2. At the end of the third day, blood and esophageal tissue samples of all rats were taken for histopathological and biochemical evaluation. What we looked histologically: inflammation, epithelial loss, hemorrhage, damage to the muscularis mucosa, increase in mucosal collagen, and damage and collagen deposition in tunica muscularis. Also, we measured total histopathologic damage score. I will mention next slide. And the stenosis indexes were calculated, esophageal wall thickness to luminal diameter ratio. Here are our group's results. Total histopathology score is this one. Inflammation, epithelial loss, all these scores obtained all together, sum up all together, and we obtained the total histopathologic score. And as we looked at the results, Group 3, to remember, we made the burn group and received normal saline, and Group 4, we made burn and received silibinin. There are significant differences between the results, the hemorrhage and stenosis indexes. There were significant differences, and other parameters were not significant. To sum up, I can say it has therefore been found that silibinin has positive effects, in part on burn healing, partially. Thank you.
Okay, thank you very much. Do we have any questions from the audience? You actually have 2 more presentations.
And again, an experimental study, very similar to the previous one I mentioned. And in this study, we performed in order to examine the effect of N-acetylcysteine and ethyl pyruvate, both known with antioxidant and antioxidant effects. And we used again sodium hydroxide to make corrosive burn. In this study, we have 5 groups. Again, each consists of 7 rats. Group 1 received no burn, and Group 2, 3, 4, and 5 received 0.2 milliliter, 25% sodium hydroxide. Again, rats were first anesthetized with 50 milligram per kilogram ketamine and 5 milligram per kilogram xylazine. In order to reduce pain, we gave them 1 milligram per milliliter paracetamol. And again, inflammation, epithelial loss, hemorrhage, damage to muscularis mucosa, increase in mucosal collagen, damage and collagen deposition in tunica muscularis were evaluated. Again, total histopathologic damage score was measured. As a treatment, Group 1 and 2 received no treatment. Group 3, 4, and 5 received treatment. Group 3, 30 milligram per kilogram N-acetylcysteine intraperitoneally. Group 4 received 50 milligram per kilogram ethyl pyruvat, and group 5 received both of them together. Here are two tables, but I will talk about the second table mainly. The first table, all the parameters we have looked on the rats, and the second table, the total histopathologic score and stenosis index. I will talk about total score. Total score was significantly different between group 2, and we compared group 2 and other 3, 4, and 5, fifth groups. There were significant differences between group 2 and 3. As to remember, group 3 was taken N-acetylcysteine, and group 5 received N-acetylcysteine and ethyl pyruvat. There were no significant differences between group 4 and 2, and the stenosis index score was similar to total histopathologic scores. Again, to sum up, we found that N-acetylcysteine use alone or N-acetylcysteine use together with ethyl pyruvat has may be useful in healing esophageal burns associated with sodium hydroxide.
Any questions? Yes.
Did you give the N-acetylcysteine intraperitoneally?
Yes.
What's the action mechanism of intraperitoneal cysteine for esophagus burns? Because intraperitoneal region is not a connection with esophagus. I didn't understand the mechanism.
You say anesthesia?
No, I say, did you said you give the N-acetylcysteine intraperitoneal?
Yes.
What's the action mechanism of N-acetylcysteine intraperitoneal region to esophagus? I asked.
We sedatize them and then form the burn model with gavage to sedatize them.
You give the drug to intraperitoneal region to heal the esophagus burn.
Yes.
I didn't understand the mechanism of intraperitoneal N-acetylcysteine to heal the esophagus.
No. Anesthesia is not given to heal the
I understand.
Maybe I can help him. We gave NAC therapy because intraperitoneally, because you cannot give NAC therapy to an experimental study intravenously. IV rat. That's why the reason why, because it's the system. It shows the systemic effect when you administer it intraperitoneal. So it's the same in the rat study. So you cannot give IV procedure for an experimental study. Yeah, that's the reason why. Okay.
Thank you. An experimental study and the effect of resveratrol on ischemic tissue injury in experimental carbon monoxide poisoning. The aim of this study was to investigate the protective effect of resveratrol on the ischemia, inflammation, and oxidative injury on brain and heart tissue, experimentally induced carbon monoxide intoxication. To remember, resveratrol is a natural polyphenolic molecule with known anti-inflammatory, antioxidant, anti-apoptotic, and anti-aging effects. We have 6 groups in this study. Each contains, again, 7 rats. Group 1, 2, and 3 received inhaled room air for 60 minutes, and group 4, 5, and 6 received 4 liters per minute, 5,000 ppm carbon monoxide inhaled. And as a treatment, group 1 and 4 received 1 milliliter normal saline, group 2, 16 milligram per milliliter dimethyl sulfoxide, and group 5 received the same. Dimethyl sulfoxide is the solvent of resveratrol, and group 3 and 4 received 25 milligram per kilogram resveratrol intraperitoneally. Carbon monoxide level, we measured it from the tail vein with 1 milliliter blood. At the end of the 48 hours, rats were sacrificed by decapitation method. Blood, brain, and heart tissue samples were taken. In brain tissue, histopathologist looks neuron damage score, percentage of degenerative neuron, apoptosis rate of cortex, and hypothalamus were calculated. And In heart tissue, myocyte degeneration, vascular congestion, and myocyte apoptosis rate were calculated. Also, biochemically, total antioxidant score, total oxidant score, and oxidative star index were calculated. Here are the results of our study. To compare the group 4, to remember carbon monoxide and normal saline, and group 6, carbon monoxide and resveratrol, there were significant differences between neural damage score, neuron degenerating rate, cortex apoptosis rate, and also myocyte apoptosis rate comparison were significant. Biochemically, I said we have looked at total antioxidant score, total oxidant level. There were no significant differences between these groups, and so I didn't put the table here. As a result, I can say resveratrol administration in experimental setting may be beneficial in treatment injury to secondary to carbon monoxide tissue in brain. Thank you.
Thank you very much. Any questions from the audience? Thank you very much. We'd like to thank you and all of our presenters in the oral research session. Good afternoon.
Thank you.
Okay. Hello, everyone. Good afternoon. First of all, I want to say I am very happy to be with you in this great organization. I want to thank you, MENA Talks, Ziad Kazi and Beşer Al and İpet, Big Boss Başar Cander. Today, third day of great organization. Our session is in the golden hour management in the emergency department. We will talk very important topics from valuable speakers. I want to invite our first speaker, Dr. Eren Gökdağ, will make a presentation on carbon monoxide. He's working as an emergency medicine consultant at Yeditepe University Hospital. He's PhD student in toxicology at Yeditepe University of Department of Pharmacology. Yes, please.
Okay. Hello. This session is about golden hour management in emergency department, but because of the nature of majority of carbon monoxide poisonings, it's not that possible to start the treatment within the first hours. I think everyone knows what carbon monoxide is. It's well-known toxicant. It's colorless, odorless, and tasteless gas. The carboxyhemoglobin levels for non-smokers can be up to 5%, and for smokers it can be up to 10%. Carbon monoxide poisonings is a leading cause of accidental poisonings, but we are bad at data management in our country, so I don't have national data. But according to Global Health Data Exchange 2017 report, the worldwide cumulative incidence and mortality of carbon monoxide poisons were estimated at 137 cases per million and 4.6 deaths per million, respectively. And it also published in Lancet 2018. Clinical manifestations are vary, and these manifestations and severity of clinic doesn't correlate with carboxyhemoglobin levels. Because of this the variation of clinic manifestations, even most of the time patients even don't know that they are affected from carbon monoxide poisoning. Treatment is simple. We give oxygen, 100% oxygen as soon as possible. If there is a cardiovascular compromise, we can give IV fluids, inotropes, and if there is a life-threatening dysrhythmia, we initiate the standard advanced cardiac life support protocols. And also we give supportive treatment for seizures, to benzodiazepines for seizures. Half-life of carbon monoxide changes with method of oxygen delivery. We know that it's in room air, half-life is 4 to 5 hours, but with 100% oxygen, it decreased to 80 minutes, and with hyperbaric oxygen therapy, it will reduce to 20 minutes. Pardon. We have very oxygen delivery methods. These are the high flow nasal cannula is a new method, and non-rebreather mask is our traditional way. CPAP is also one of the newer methods, and hyperbaric oxygen therapy is the most effective weapon against carbon monoxide poisoning, but it has some challenges in itself. These are the newest studies about high-flow nasal cannula. Oxygen via high-flow nasal cannula is a newer method, like I said, but they found useful in some cases. This is one case, a young male patient, and they found that high-flow nasal cannula can be useful for carbon monoxide poisoning, and it is more comfortable than traditional methods. And this one is also another study, but they compare with it conventional face mask in this study, not non-rebreather mask, but it also has lower half-life than room air. And this one is also a new study. But their sample size is low, so they say that this is promising alternative, but we need further studies to earn its place for the treatment. And this is, I think this is the only study that I can find for CPAP. They compare the CPAP with non-rebreather mask, and the half-life is significantly reduced by CPAP. But like I said, in high-flow nasal cannula, it will only for suitable cases. It's not that comfortable like high-flow nasal cannula. Hyperbaric oxygen treatment is controversial. We know that it's useful, but we don't know how useful. Hyperbaric oxygen therapy increases blood oxygen content rapidly, and it has additional effects on neutrophil adhesion to blood vessels, on restoration of mitochondrial, oxidative, and immunological disturbances caused by carbon monoxide. But the fight continues about how useful hyperbaric oxygen treatment is and in which cases we should use it. Despite the fight, we have suggested indications. You can see that. These suggestions generally covers for serious patients like coma, seizure, altered mental status, and abnormal cerebral function and fetal distress in pregnancy. But it doesn't prevent from the patient from delayed neurological sequelae, 100%. Even the patient had mild symptoms and relatively low carbon monoxide carboxyhemoglobin levels. Delayed neurologic sequelae can still be seen in these patients. So we still didn't know the exact patients which we should use the hyperbaric oxygen treatment. This is a study of ours. We found that initial neurologic examination, if there is a pathological initial neurologic examination, has a predictive value for delayed neurological sequelae, but carboxyhemoglobin levels weren't correlated with delayed neurologic sequelae. There is too many studies which conflict with each other about hyperbaric oxygen treatment on carbon monoxide poisonings. At least we know that hyperbaric oxygen treatment is useful in some degree, especially if start within the first 6 hours. So we are continuing to use it as a standard. Thank you for your attention.
Thank you, Dr. Eren Gökten, for this very well presentation. Do you have any question or adding?
I think no. I think.
Have an opinion in ECMO for carbon monoxide?
Sorry,
ECMO.
ECMO. It is because of the subject is golden hour management of emergency department, and ECMO isn't generally used. So I didn't cover the ECMO in our presentation.
Okay.
But there is studies that blood transfusion and like ECMO is useful for carbon monoxide poisoning, but it's not that practical. So,
thank you.
Yeah.
I'm Ziad Kazi, and it's my pleasure to bring you today a special course, a new course for MENA Talks called RIMIC, which is Recognition and Initial Management of an Illness Cluster. This course is based on several incidents and events that happened to me as well as to the region. As you know, we are now facing a new normal in our region, unfortunately, where we have chemical weapons and we have chemical attacks. When I was a fellow in toxicology, of course, all toxicology fellows study chemical warfare and chemical weapons. We usually study them, and historically. I never imagined that in the 2000s, I was having to think about attacks in Syria and see if they were actually chemical attacks, or in Iraq or other parts of our region. The other factor that led to this course is that over the years, I've been involved in situations where several people develop an illness of unknown cause. And we have to think through the cause of this illness. And many people teach about these type of illnesses, but they usually focus on viruses, bacteria, chemicals, radiologicals. But this doesn't help us in the ER, right? In the emergency department, does this help us? We are sitting there, a patient shows up with an illness. They don't tell us I'm a chemical patient, I'm a biological patient. They come undifferentiated. And only through proper history and physical exam and proper thinking can we really find out what's going on with the patient. And this is why we decided to create a course that really focuses on the clinical manifestations. Primarily that. You will not see a lot of treatment information. This is more a course to help you remember what could this be. What other things can be causing this illness. Even if they're not likely, but possible. And just the fact that you think about these possibilities, I think is an important thing. The chemicals that we can see in these incidents can be varied. And from Syria, for example, we know that initially we had nerve agents. And then when we had the tragic incident in Ghouta, they signed the Geneva Convention, and then there was a ban on destruction of the nerve agents. But then we saw more what? Chlorine being used. So there's a variety. And we even saw sulfur mustard in Syria. Of course, Iraq has many cases of sulfur mustard and other chemicals that we will talk about later on. Now, disasters usually are defined as an act of nature or an act of man, which is of sufficient severity and magnitude to warrant emergency assistance. This is kind of a nice, big definition. But really a disaster at the community level is any incident that overcomes or is beyond your capabilities or capacity to deal with it. And an incident that disrupts your day-to-day activities or normal functioning in your emergency department. There are natural disasters and there are technological disasters. The natural ones are not going to be discussed today, but of course are an important type of disasters. The technological disasters are what we will focus on today, and those are usually either overt or covert. Covert is like what Dr. Hamoudi will see with thallium poisoning, for example. It's a covert incident. Overt is when there's an explosion, for example, and release of chemicals. It could be accidental, like a release of chemicals from an industry, or intentional in an act of terrorism. A cluster is what we're going to talk about today, is a group of unusual aggregations of illness amongst people in a community. These people usually are affected or exposed in the same place or similar place potentially. They have things in common, place, or they have time in common, occupation, and those are usually called a cluster of illness. And those can come to your emergency department, and that's why we are going to go through the differential diagnosis of such patients. CBRNE is a term that replaced the old term in World War II, which was NBC. So CBRNE is chemical, biological, radiological, nuclear, and explosive. Now these are usually military weapons, for example. Some of them are used only for military purposes. Others have dual use. An example of a military CBRNE chemical is chlorine, which is also used in industry. But those are not the only chemicals we have to worry about, or agents that we have to worry about. There are toxic industrial chemicals and toxic industrial materials and toxic radiological materials. Those are all over the place. They are around you at hospitals, at industrial sites, and those are the ones that can be also used easily. And if they're intercepted, if the chemical security is not robust around them, or the biosecurity or the radiological security is not robust around them, they can be apprehended by a terrorist and used. This is why today Dr. Andy Nelson is going to talk about that in more details, about how to think about the security of these materials in your environment, in your community. So let's look a little bit at the chemical, biological, and radiological characteristics. And I'm going to actually turn around here so I cannot see that far. If you look at chemicals versus biological versus radiological, the first thing is, can they be disseminated over a wide area? Chemicals can, especially when they are gases, for example. Biological, on the other hand, are difficult to disseminate over a large area. Usually, they tried to have these biological bombs, for example, in the past, by dropping them from airplanes and spraying brucella or spraying other type of tularemia. But they don't really work that well, and heat can deactivate them as well, so that's a challenge. And also, how do you store them and to use them in the battlefield? Radiological may or may not affect a large area. A nuclear weapon detonation, for example, can affect a large area. A dirty bomb can affect, a significant area. But a radiological device that you put in a room can only expose people around the device. And the further away you are from the device, the less radiation dose you get. As far as security is concerned, chemicals and biological agents have low security because they are used on a day-to-day basis, and they're available at hospitals, for example, and they're easily manufactured or grown in a lab. So the security of these is low, and I would not say more than that because I think Dr. Nelson will talk more about this. Radiological agents vary. There are some radiological agents that are very secure, like uranium, for example, or plutonium. Some are less secure, like, let's say, technetium, or things you use in nuclear medicine, or things you use in industrial settings. As far as the delayed presentations, so this is important for our course, RIMIC, what can cause a delayed presentation of illness. The chemicals usually are going to cause an acute effect, although there are some that cause delayed presentations. A great example of that is dioxins. Another example of that is methyl mercury, and those can have delayed onset of illness. Okay? The biological agents, yes, can cause delayed illness. There's an incubation period, and then there's an illness. Except if you're thinking about a biological illness due to a toxin, like botulinum toxin or ricin, those may have an earlier onset illness. Radiological agents, by definition, have a delay. Radiation rarely cause very severe or overt acute symptoms, usually delayed. As far as the transmissibility of these agents, chemicals are not transmissible usually. But biological, yes, you can transmit a disease from one person to person, depending on what the agent is. Radiological, you could potentially transfer contamination, but that's not really transmissible. So usually we don't think of radiation as transmissible. Biological agents induce immunity. Chemicals and radiologicals do not. Decontamination is important for chemical and radiological, more for chemical than for radiological. It's more important for chemical events than for radiological events. Biological usually does not require decontamination unless you have, for example, anthrax spores that you're trying to clean up. Finally, treatment. For chemicals and radiologicals, it's primarily supportive care with antidotes or countermeasures. For biologicals, now you're thinking about antimicrobials, antivirals, and then vaccines. So I hope with this in mind today, you will use this information every time you see a cluster to try to differentiate, whether it's chemical, whether it's biological, whether it's radiological, depending on this type of information. And also broaden your mind, because the dose is what determines the poison. Really, everything can be poisonous depending on the dose. So don't just look for the ones that are definitely poisonous. Look at any chemical and assess the situation specifically. Is this situation, one where it's a not toxic chemical, but the dose is high, and therefore it can be explaining the effects? You also must really look at the physical properties. We probably don't do that a lot, but you should look at the pH of a substance. You should look at the boiling temperature or the freezing temperature, the vapor pressure at room temperature. What are the warning properties of this chemical or this radiological agent, for example, which usually is very poor for radiological agents. They don't have warning properties because they don't smell funny, they don't look funny, and certainly they don't glow. Chemical agents, on the other hand, may have an odor or may cause an irritation, but it depends on the chemical and how good these properties are to warn people when they are exposed to them. Also, when you look at biological agents, it's important to understand the incubation period. And is it transmissible from person to person? And then how long are you infectious? And what is the time course of this illness? So having this information in your head, I think, is important. If you can't remember it, you have to look it up when you're facing a situation to be better able to respond to the needs of your patients. Let's talk a little bit about warning properties. So the warning properties, such as, for example, odor, may or may not be sufficient or protective. What is the point of you smelling something when the concentration at which you smell that chemical is lethal? Right? Ideally, you want to be able to detect the smell of a chemical at a concentration that is very far from the lethal dose, right? So that you smell it and run away. The other problem with smell is that some people don't have a good sense of smell for certain chemicals as well. It's a lot of genetic factors involved. And there's something called olfactory fatigue, where the nose stops detecting a specific chemical. A great example is what? Which chemical? Thank you, hydrogen sulfide, which causes this olfactory fatigue. And people would smell it for a short period of time, and then they get reassured that it's not there when the smell goes away, when actually it's still there, it's getting higher and higher, and they're going to die soon. Cyanide gas is thought to have a bitter almond smell, but people cannot smell that. Not every person can detect the bitter almond smell. So those are poor warning properties, for example. I hope you remember to use the agent-host environment tool in your response. Every time you are faced with a disaster or a cluster of illness, stop, pause, and think about what is the agent, who is the host, and what is the environment. This is an old epidemiological tool used in public health for infectious disease outbreaks. where they use it when they're dealing, for example, with a malaria problem in a location. We use it for the chemical and radiological in the following manner. First of all, assess what is the agent. Think about it. Could this be a chemical? Could this be a biological? Could this be radiological? If you don't go through this exercise, you'll miss it. I'm not saying every case it is going to be an exotic radiological event, but at least think about it for a second. Okay? And think agent, okay, let's see. Could this be a chemical? Could this be a biological? Could this be radiological? And okay, let's say you know what the chemical is or the substance is. What do we know about this substance? Is it, a gas, a solid, a liquid? Is it radioactive material in a solid form? Does it emit gamma rays or beta particles or alpha particles? What is the decay products of this radioactive material? Is this a bacteria or virus? Okay. How much of it are we talking about? Is it a lot, a little bit? Is it potent or not? What is the toxicity? What is the route of exposure that is really bad for this specific substance? The next thing you can go through is the host. Who is the victim? Is this a person who is wearing a mask because it's a military person wearing a gas mask on a battlefield? Or is this a child, a pregnant person? Is this somebody who already has immunosuppression that's been affected by radiation? All of these should go through your mind as you are assessing a situation. And what is the environment of this exposure or this event? Was this at a bus stop, like we saw yesterday in the outbreak investigation workshop? Was this outside or inside of a building? Because inside of a building, theoretically, you don't need as much substance to affect people as if it was outside the building, because outside, it's going to evaporate. What are the environmental conditions? What was the temperature? Sulfur mustard in Iraq and Iran caused more respiratory effects than in Europe because of the environmental temperatures conditions. So you need to analyze all of these factors when you look at the incident. An example of that is Bhopal in India. In Bhopal in India in 1984, what was the agent? Methyl isocyanate. What do we know about methyl isocyanate? It's an irritant. Does it contain cyanide? It contains a cyanide molecule, but it doesn't cause cyanotoxicity. What else do we know about it? We know about it, it's highly water soluble. And what else do we know about it? Amount, large amount. This was a chemical used to make other chemicals, so they stored a lot of it in that, on that site. So large amount, irritant, water soluble. Does it get absorbed into the body? Unlikely. It's more of a irritant without significant absorption. Who is the host? Poor people living in structures that are not very protective and living very close to the actual plant. Not very, nothing else special about them. They're just normal people, families, children, adults, men, women, but probably with poor access to care. Knowing, some of these rural areas in India, they probably have poor access to care. What is the environment? The environment was outdoors, open air environment. However, there was an environmental condition which led to temperature inversion, which led to the methyl isocyanate not evaporating and dissipating in the environment. It kept it kind of a lid on a pot, hugging the ground and affecting more people. So analyzing this event using agent-host environment helps you understand the event better and potentially helps you look for specific injuries based on your assessment. Let's think about Georgia, the Republic of Georgia, where there were two woodworkers, people that collect wood from the forest, in a very remote area in Georgia. These people found these two canisters in Georgia, and the agent here was strontium. It's a radioactive compound, strontium. It emits radiation, gamma rays, and it also emits heat. And it's usually used in these remote areas to generate electricity. They're radiothermal generators that are placed in remote areas where it's hard to get electricity to, and they generate their own electricity. They were left behind by the former Soviet Union, because Georgia used to be a country in the former Soviet Union. They were found by these woodworkers. So who is the host? 2 woodworkers, 2 people, healthy. Nothing else unusual about them, but at least just only 2, not 100. What is the environment? The environment was outdoors. They found it. It was a remote area, very cold. And because of this, they wanted to heat themselves, and this was emitting some heat, so they thought this is a heat source. So they carried it on their body and to their tent and slept close to it. So that's the environment. And because it's a radioactive material, when you think about what is the agent, gamma rays are going to expose people at a distance. And that's what happened to them. They developed the radiation injury to their back with the cutaneous effects, as well as the bone marrow suppression. One of them died, the other one survived. So finally, just want to pause a little bit here and have you think about this. How prepared are you for a CBRN incident? Think about that. Are you prepared? Well, we have some research that shows we're not. For example, Dr. Bashar talked about or Dr. Samih Korkut talked about the large number of volunteers in Turkey for disasters. We did a survey in the US of our volunteers and asked them about their attitudes and comfort level with a variety of disaster scenarios. And clearly, they were much more comfortable responding to a weather-related emergency than they would be for a chemical or biological or radiological. They're more scared of responding to that. And I think that'd be a good project maybe in Turkey if it hasn't been done to assess the volunteers here's perception and comfort level with these events. I did a survey amongst emergency medicine physicians several years ago and asked them about radiation knowledge questions and comfort level, and the results were surprisingly, surprising because they were uncomfortable and unaware of many of the basic knowledge of radiation injuries. So I think we have a long way to go in this area, and we need to certainly try to train our colleagues in this field, because without knowledge, you cannot have preparedness. You can have all the PPE and all the antidotes and all the ambulances of the world, but if you don't have the knowledge, how are you going to respond, especially when you're a physician, required to assess, analyze, and treat. Now, that may be difficult when you think about the thousands or millions of potential scenarios out there. Thousands of chemicals can show up through your door. Thousands of types of radioactive material or viruses or bacteria. It can be overwhelming. And there's no way you will be able to remember every single chemical or radioactive material. And it's no shame in looking something up and trying to get some more information about something. So finding the right resources is important in your response. But you do want to at least start thinking about what could this be. And you cannot wait too long. These are emergencies. So you must start assessing the situation and getting the appropriate laboratory analysis. But that's going to take time if it's available. Some chemicals or biological agents, have diagnostics that are not always available, and some require several days to result. In the meantime, you must take care of the patient. So you need to look at the clinical picture, and you need to know at least which category it fits under, and then start managing it safely and effectively as you get more information as time goes by. So we recommend using this approach of RIMIC, which is really the toxidrome-based approach or syndrome-based approach. And the knowledge that you get today in other training courses helps you enrich your differential diagnosis so that you're able to go through a list and see which one is possible, which one is less likely, and which one is more likely. And the CDC, for example, has published a list of chemical toxidromes, for example. And this is available online for free, and you can look through the list just to help you, define some of these categories. But today, we'll try to hit up some of these categories. Irritant is something we are going to cover. asphyxiant, maybe less so, but we'll talk about anticholinergic, we'll talk about sedative, opioid, stimulant, we'll talk about corrosive, and then we'll talk about a little bit about radiation exposure. This is not an exhaustive list. There are potentially other syndromes out there, but this is a place to start. And the more important thing is to learn how to think through this process rather than go through every single category. So I hope you'll enjoy the rest of the day, and I think we're going to try to stay on time and hopefully finish maybe an hour or 30 minutes earlier than what is scheduled. This is a CAM website, which is available online for free by the National Library of Medicine. It's also an app. It's a resource to help you put together signs and symptoms into different boxes and guide you towards a potential toxic drone. Thank you. Any questions? And then we are going to take questions today as they come. So Dr. Brent Morgan is a professor of emergency medicine at Emory University and is the vice chair of education. What is the new title?
Strategic Initiatives.
Vice chair of strategic initiatives at our department and the residency program director for medical toxicology at Emory. Dr. Morgan?
I need module 2. Yes. And this says module 3. Maybe this is still it. Okay, cool. Is that the one? Yeah. All right, so our objectives today, we're going to be able to list 2 reasons why the GI system is uniquely susceptible to toxicological insults. And then also be able to name the cause of the largest bioterrorist attack in the history of the United States. And so we're going to be talking about GI clusters, so how different exposures potentially result in a GI illness. You can see the GI tract in the diagram there, starting at the mouth and ending down at the rectum. And the GI tract is uniquely susceptible really for a couple reasons. I mean, one, it's a site of contact, right, where a lot of pathogens or toxins can first come in contact with the body. And then also the amount that's going to come in contact is going to be at the greatest at that time when it's touching the GI tract. It also has rapidly dividing cells. And so toxins that make it so that you can't divide anymore, we'll talk about some of those, are going to affect there, and then you're going to start seeing the symptoms. And then the effects and symptoms are pretty readily apparent, right? So we're talking about people having abdominal pain, vomiting, or diarrhea. And so clinically, we can see that, right away as soon as those symptoms develop. Whereas opposed to the other organ system, the hematopoietic system, that's our bone marrow making cells, it also has rapidly dividing cells. If both of these 2 systems are having adverse effects from a toxic exposure, you got to wait until you start seeing the problems with the bone marrow. So the cells that are in their blood are still going to be there, and you got to wait for those to naturally decline, and they're not able to replace them. So you're not going to see that. We're going to focus mostly just on the GI tract in this, but obviously there are other organ systems in our gastrointestinal system, including our pancreas, our bile ducts, our liver. Just a little bit about liver. It also gets exposed to a relatively large concentration of a substance that we ingest because it gets the first pass effect that you absorb those things through your gut, goes right up to the liver. So it's going to get a significant exposure. And the liver is also metabolically active. I mean, a lot of tissues in our body are metabolically active. The liver is by far the most metabolically active. And so when it attempts to metabolize these substances, sometimes it can form a more toxic compound then that can have adverse effect on the liver itself or throughout the body. So again, we're going to focus mostly on patients that are having abdominal pain, nausea, vomiting, and diarrhea. And you can look into different tables about the color of the vomit and the color of the diarrhea. I'm colorblind, so it doesn't help me, but you can always look those up. And we're basically going to go through a series of cases of real events that occurred
and whenever we kind of discuss this and talk about differential. But a broad differential, there's obviously the infectious, and usually that's where most of the money is going to be, right? When you have someone comes into your emergency department or you get a cluster, several people, it's usually going to be some sort of infection. They had food together that was contaminated, and most of the times you're going to be correct in that. And so you're looking at different bacterial infections. There can be ones that produce toxins, such as like staph toxin, and those are going to be more rapidly acting because the toxins there is going to start causing the adverse effects, versus ones that are more infectious, and those can be a little bit more delayed as far as they're invasive. You ingest them, then they have to invade into your intestines and then start causing the symptoms of the infection. Obviously, a lot of virals out there, like rotavirus, for example, parasitic, which can be even slower in onset. Radiation can certainly affect the GI system and result in abdominal pain, vomiting, diarrhea, and so we'll talk further about that. And then we get into some of the toxicants, so things that don't occur naturally, and potentially be man-made, or they're not made by a living organism, I should say. So there are a lot of metals that can have adverse effects on our GI system. Things that enhance serotonin potentially can cause GI symptoms because we have a lot of serotonin activity in our gut. Cholinergics, the big one being like organophosphates and carbamates, besides having other symptoms, can obviously have a predominant amount of GI systems. Things that cause cell death or interfere with your cell's ability to divide by making it stick in mitosis because the microtubular apparatus can't work, can also then affect the GI system. And then just your plain irritants, things that kind of irritate, and that would be like your laxatives, for example, can make you have the diarrhea. And then toxins, so substances that are made by living animals or living organisms, I should say. So obviously there's a variety of plants that it should not be ingested. If they are ingested, it can cause GI symptoms. English ivy would be a good example of that. Different mushrooms or fungi. There's a lot of mushrooms that just cause GI effects, and that's it. There are other ones that can cause GI effects and then cause problems with your liver, like the Amanita species. And then the marine toxins that we think about, such as ciguatera, brevetoxin, the ones that are from shellfish poisoning. In addition to having some other symptoms, including like neurologic symptoms, they will present with the GIs at first. So a pretty broad differential. If you get more than one patient who were there kind of together at a certain place, who are having problems with their GI system, such as nausea, vomiting, diarrhea, then that's when you need to start reaching out for help to do some epidemiology about what's going on, and it's immediate importance. Obviously, the main cause of these events are going to be infectious, and that's when you're going to want to reach out then to your infectious disease colleagues. And then at some point that you may want to order an infectious disease officer at your hospital. And at some point you may need to get your government involved, because they're the ones that have the resources and the capability to really investigate it, to leave the hospital, to go to where the site was, where the inoculation initially occurred, and then try to do the work there and help in identifying what was going on, and then potentially hopefully to limit its spread so other people don't become sick, or identify other people who may be sick but they're just at home toughing it out, and you may be able to give them proper care. All right, so we're going to run through again a few cases here of clusters of GI illnesses. So this one occurred way back in 1984 in Oregon, which is a state in the northwestern part of the United States. And in September, many people started developing an illness, a GI illness with diarrhea, fever, chills, vomiting, abdominal pain, and having blood in their diarrhea. And this was in a rural area. I think the main town there had roughly 12,000 people, I think, as their population. And then by the end of September, there were over 700 people who had developed this infection. And they'd done some lab testing on them and determined that it was a Salmonella species that was causing this infection. So the State Department of Health started an investigation, and they ended up finding out that all the patients had dined at one of 10 local restaurants, in the area. And the investigation identified this Salmonella species at those restaurants and their salad bars. And they concluded that the outbreak had been due to the food handlers there having poor personal hygiene, that these food handlers also had caught the disease, the infection themselves at some point before most of the people in the community did, and that they didn't use good hand hygiene, and that's what continued to spread the infection. And so they shut down the salad bars and all these restaurants, and then assumed that had taken care of it. I guess kind of reasonable suspicion, but the locals there had other suspects. They didn't believe what the state had told them. And at the time, there was a community that had recently moved in to their rural area of several thousand people, and they were following this guru or this spiritual leader, and they're called the Rajnas. And you can see here is the picture of him in his car driving up, and all of his followers lining the road for him. And then here's the speaker himself. And they were highly suspicious of that this group had something to do it. As I said, they had moved into this community for a few years before that. There was a smaller town in this community called Antelope, and they had essentially. Then once they took this over, they ran for office in that smaller community. They won the electoral races, and then they actually changed the name of the town, after themselves to the Rajnas. And then they were running candidates in this upcoming election that was going to be coming up in November, the beginning of November as well. And they were trying to sort of take over the county, government. Ended up being that in the election that occurred in November, they had a massive turnout of locals, and they actually were pretty strict then as far as who they allowed to vote. You had to prove that you had, residence there, proved you had to be a citizen of the country, and so they end up the followers of the Rajnas did not win the election, but again that was more in November. A local U.S. congressman from that area was also convinced that there's something going on, and that it was that it wasn't just the salad employees or the employees of the restaurant that caused this. And so they actually called on CDC to further investigate and asked U.S. government to try to investigate. However, most of the government officials, thought these locals were just being kind of bigots against the Rajnas and were prejudiced against them as well, and so they didn't give them a lot of concern to their pleas. However, then that following summer, this leader of the Rajnas, again, the spiritual guru, he actually at the time had been on a 4-year period of public silence and self-imposed isolation while he, was doing his thing. And then shortly after he came out, he started talking to his followers and heard that some things had happened while he was in this period of silence, and that some of his followers had, in fact, been responsible for this outbreak of the Salmonella. And so this was actually a little a trial run they were doing to see how many people they could infect. And then they were going to try to do a bigger one in November when the election was, to see if they could get even more of the community ill with this from Salmonella or some other type of infection, so they wouldn't be able to go and vote. And then their followers wouldn't have the infection, and they'd be able to vote more and get more of their people elected. And so after he announced that his group was responsible, then the authorities came in and they had their own medical clinic, and they actually found vials of the Salmonella that were an exact DNA match to the Salmonella that people in the community had developed. And what they had actually ordered it, and they had the receipt from a lab in Washington State, the Salmonella species, and they continued to kind of grow it there at their clinic. And they had went to the salad bars and sprinkled the Salmonella there on the public salad salad bars, and then people would come and consume it, and that's how they got infected. There were no deaths from this, and which is great. Very fortunate, and they ended up doing prosecution against several of the members of the group. The leader claimed he didn't know this was going on. Again, that he was in his public silence period, and so he was not charged. And this ended up being the single largest bioterrorist attack in U.S. history. The next cluster that I want to talk about, this would be a patient who presented to the emergency department with nausea, vomiting, having profuse diarrhea, and also happened to having chest pains. She had a past history of having fibromyalgia and back and neck pain. And she'd been going to an alternative practitioner, or what we call a naturopath, in the United States. These are people who kind of sometimes do some weird things that's out of the mainstream as far as what most physicians would do. And she was receiving these infusions once a week for her back and her neck pain. Her symptoms started about 1 hour after her last infusion, and once the symptoms started, actually the naturopath of their office told her, well, go to the emergency department and see if they can do for you. Initially, her labs were unremarkable, except for an elevated white count, and then she got admitted for IV hydration and observation, and they were concerned about infection, so they sent cultures on her. A repeat white count that was done several hours later was also even more elevated and had a lot of immature forms on it as well in the differential. But then over the next 72 hours, her laboratory analysis and her condition continued to worsen, where she developed multi-organ failure. You can see that she developed low white count, low platelets, so she's having bone marrow suppression. She developed acute renal failure. She developed rhabdo. She developed a lactic acidosis, and she developed some hepatotoxicity, and then also had a pretty dramatically elevated troponin. Any thoughts on what she could have been receiving? Ricin, okay. It's a good thought. Well, ricin is something that shuts down cell replication, so through ribosomes and elongation factor 2, so that's something that potentially maybe this naturopath was trying to give a little bit of that. Or colchicine. Yeah, colchicine would be a great differential here as well. Colchicine affects your microtubular system so that your cells can't divide. That also shuts down cell replication, so you're going to see the GIs and then bone marrow suppression and then multi-organ failure. So on the third hospital day, she developed ARDS, then hypotension, cardiac arrest, and unfortunately died. And then they had gotten the history of what this naturopath was administering. Ended up sending a post-mortem level. It came back at 32 nanograms per cc. And you're right, that was colchicine that she was receiving in this alternative medic clinic. This was something that was, again, some of the alternative medicine practitioners in our country were using colchicine for different back pain, neck pain, fibromyalgia. It has its anti-inflammatory properties that it has. And then the state of Oregon, then were able to look into this a little bit more, and they identified 2 other people who probably had died also in the intervening months from this therapy. And they looked further into it and found that these alternative practitioners, where these deaths were associated, were buying this colchicine from a compounding pharmacy. And those are pharmacies in the United States where they're not highly regulated, they're not big pharmaceutical companies, and you can contract with them to make a medication for you. And sometimes they have problems with infectious outbreaks. They're not as highly regulated, and then also sometimes with concentration issues. And ended up being that they got the vials of the colchicine that were actually being administered in that lot that they had ordered, and find out that they had 8 times the amount of colchicine that they were supposed to have. And we know that colchicine has a very narrow therapeutic range, and so that difference in dose can potentially be lethal. And so because of this event, again, this was in the early 2000s, the FDA had some rulings on this, and so they first made it so that individuals who were making intravenous colchicine had to stop, and then they were not allowed anything they had there with them. They had to stop selling after 180 days. And then after that, all injectable colchicine products had to be FDA approved. So compounding pharmacies were no longer allowed, just to kind of make it up on a whim and send it out, that they're going to have to be approved by the FDA and go into pretty rigorous standards. So this is an important point also as well, that don't assume that when you have an outbreak and you think it could be tox related, that what on the label is correct, right? So you need to really go there and you need to look at the concentration of everything they've been getting, and whether it's even mislabeled, and maybe they're getting something else. And so that's an important part. And do you guys still have IV colchicine available here in Turkey? Okay, so again, the FDA instituted this in the United States 2008. Before that, we could give IV colchicine pretty readily in the hospital if we wanted to for acute gout attack, for example. And then in 2006, this is even before this outbreak occurred, colchicine, has been kind of, was never really FDA approved. It just got sort of grandfathered in because, as I said, it's been used for centuries, and just got kind of accepted as a medication without having to go under rigorous studies to get FDA approval. But in 2006, FDA came up with this new process that they call the Unapproved Drug Initiative, so drugs that are out on the market. If a pharmaceutical company wanted to go and do the study to show that it was effective, then they would be giving priority over that medication, and so they'd be the only one then who could distribute it, and then thus they can set their price. Whereas if something's been there and approved or been out in the market for a long time, then smaller pharmaceutical companies that makes generics can make the drug themselves as well, and that usually brings the price down. So then in 2009, a drug company in the US then did the studies and published it, and they got FDA approval for the oral colchicine. And then so since that was only got FDA approved, then no one could come and start giving IV colchicine because this is the only form that has FDA approval. So someone would, if they wanted to make a different form and have an IV, then they'd have to do that study to show it's effective, and then they get FDA approval to have it on the market. So that's since 2009, we don't have IV colchicine as well, which is fine. But then the problem is it went up dramatically in price, like over 2,000% in the U.S. It used to be pennies as far as a dose, and now it's not outrageous. I think it's like $5 a tablet, but still, it's the amount that it went up was was pretty dramatic. So as we said, colchicine, it comes from a couple of different plants, from the autumn crocus and also from the glory lily, and it's been used for centuries to treat gout and a few other diseases. I know the ancient Greeks in this area used it, the Egyptians used it, so again, it's been used for a long time. And as we said before, the microtubular apparatus, through its mechanism how it works, and then it makes it so the cells can't divide, and that's why initially we see the GI symptoms, bone marrow suppression, and then eventually multi-organ failure. Also has potential for a lot of other problems. Has a very long half-life, anywhere from 20 to 40 hours. It also, in addition to binding the microtubules, it can interfere with the cytochrome 3A4, and then also likes to bind to P-glycoprotein as well. So other drugs that are inhibitors of 3A4 or that affect the P-glycoprotein, can really wreak havoc with people who are on colchicine and can result in toxicity in them. There's been deaths that have been reported from as little as 5.5 milligrams, of it in a cumulative dose. So we know it has a very narrow therapeutic range. And then also older adults, probably people have pre-existing, renal and hepatic disease aren't going to eliminate as well, and the levels can build up, and then results in toxicity and death. All right, the next case occurred in the opposite part of the U.S., so sort of in the northeast, most northeastern state in Maine, a town called New Sweden. And here you had a 50-year-old gentleman who attended his church services, and then frequently after church, so have some treats and coffee in the back where people can kind of mingle a little bit. And he went back there and had some snacks and started a cup of coffee. And then minutes later, he started feeling nauseated. Kind of told his wife, hey, I don't feel good. So his wife drove him home, and then as soon as he got home, he started having vomiting and diarrhea. And kind of toughed it out through most of the day, but was just feeling awful. And so that evening, he got brought to his local emergency department. And unbeknownst to him, 11 other people from his church had also shown up to that emergency department with vomiting, diarrhea, and some of them had low blood pressure. So they all got, kind of IV therapy. A few of them seemed to improve and were discharged. But then about, 7 of them, did not improve that much. And so they decided that, we couldn't let these 7 go. The infection control practitioner of the hospital, who was a nurse, contacted a division of the CDC that was there in Maine that had been set up only after 9/11, when the states got kind of money to help with preparedness and some things like that. And so they contacted the CDC Maine, and they talked about the case. And they had sent cultures on everybody, and then the CDC Maine said, all right, well, tomorrow we'll go to the church and see if we can get some of the things they were eating, et cetera, and kind of test them, see if we can figure out what's going on. However, these patients who remained at the hospital, several of them continued to get worse. They needed continued fluid replacement, and actually a few of them started to need to have pressors. 4 of them got admitted to the intensive care unit, and 3 of them were transferred that evening, kind of Sunday night into Monday morning, to a higher level of care at a referral hospital that was about 2 hours away, because again, this is kind of a small community. And then in the early morning hours of a Monday, an elderly patient who was like 78 years old died. And so when word of this, occurred, then this infection control practitioner recontacted the CDC Maine and said, hey, we don't know what's going on. People are getting worse. We don't think, my physicians here don't think this is infectious because people aren't responding to normal therapy. They're getting worse. And at that time, then the CDC Maine reached out to the local poison center, kind of trying to broaden their differentials. Like, well, maybe this isn't infectious. That's what we think it is most of the time, right? When 12 people show up, with vomiting and diarrhea. And so they contacted the poison center, and they discussed a differential about what could be going on. Any differentials on this case? Aconite, so aconite would be a good potential, yes. And where to get aconite from? Okay. Any other thoughts? So iron causes like GIs, okay. Vomiting, diarrhea, hypotension, okay. Okay, so certainly that one's there. Yeah, I mean, it's a really aggressive, form of infection, invasive, and one person died of sepsis. Okay, what about other metals? You said iron. Arsenic. Okay, so they this investigation then started going full throttle. Then that next day, they got some clinical samples and had sent them off for analysis. The CDC and the health department went to the church, looked at the baked goods that had been consumed, and the things that were kind of there. They looked okay. They weren't like moldy and looked contaminated, but they sent them. Maybe someone had somehow spiked them. And then a nurse back at the hospital had gotten more history from people and was being really diligent. What did you have? What did you have? And found out that everybody who gotten ill had drank the coffee. And then she reported that then, and that made the chain up to the CDC, and so there was some leftover coffee that was there, and so they got that for analysis as well. Ended up being that it was arsenic on testing. It was in the bitter brew at this church. And so here's kind of a timeline of events that was in their publications. You can see that 12 people who presented. There actually were 17 total who got symptomatic. 5 of them toughed it out and just stayed home. Maybe they didn't drink as much coffee, they didn't get as bad. And then again, they made this call to the CDC then on that Sunday. And then on Monday, as we said, you had an unfortunate death. And the CDC staff arrived, and after they had talked with their poison center, the differential of arsenic came into there, and they had the antidote for arsenic, the BAL, mobilized and sent to the hospitals, and they decided to so high in the differential to start treating them for arsenic before they got the laboratory test back. But then the subsequent lab investigation did in fact confirm that arsenic was the culprit here. And then you had to figure out kind of who did it and how to get there. And then about 5 days after this event, a resident of the town wrote a note and said that he did it, and then he killed himself. And so that, don't really know the local politics exactly why he did this and what was his motive, but it ended up being that it was, a massive arsenic poisoning event. And so arsenic, is a water-soluble powder that produces a colorless, tasteless, odorless solution. It's been used for centuries as a means of poisoning people, and because before, we knew it was very effective, and people who wanted to murder other folks. That's why you'd have tasters. If you were someone high up in the authority that someone might want to kill, they'd let them taste it and see whether they get symptomatic first. But then we developed the ability to test for it then in the early 20th century. It's also a human carcinogen, so it can cause bladder cancer, lung cancer, skin cancers, several different types. And it's also a pharmaceutical. And so what's arsenic used as a pharmaceutical? Yeah, so for acute proteolytic leukemia, and I think it's used also for yeah. Okay. So it's a multi-organ, multi-cell toxin. Has the ability to injure the cell so that the cell decides to kill itself. It can induce cell apoptosis. It interferes with ATP production through the Krebs cycle, and that's why it's a multi-organ toxin. It can bind to a lot of different sulfur hydro groups, which are involved in a lot of enzymatic processes in our bodies. Again, that can result in multi-organ failure. It can substitute for phosphorus because it has a similar structure. The arsenic, the pentavalent does, and so that can shut down a lot of different reactions. And then it also can block, there are potassium channels, so it's at risk for causing a prolonged QT and causing torsades, and that can be what some of the immediate death is within the first 24 hours can be of a dysrhythmia. So there can be different types of arsenic poisoning, right? We're talking about acute here. There's also can be subacute, and then there can be chronic, where individuals who have it in their low levels and their well water, and then being exposed to it, like in Bangladesh, then can develop all kinds of adverse health effects from that. But with acute, you get a rapid onset of gastrointestinal effects. You get hypovolemia from capillary leak, multi-organ failure, cardiac dysrhythmias, encephalopathy, and again, it can be lethal within in a 24-hour period. Treatment involves fluid resuscitation, supportive care. you want to send testing for it, although you may have to make your clinical decision, based on your high index of suspicion, before you get that back. Initially, you can just send just collect some urine and send it off. We call that a spot. But arsenic secretion can vary a little bit, throughout the day. Usually, if you're acutely ill and got a massive poison like these people did, a spot's probably going to be pretty good. You're going to detect it, but you want to send that first urine off right away, and then start a 24-hour collection of their urine, and then send that off as well. Since it can prolong the QT, you probably want to try to stay away from other medications that can do that. Such as a lot of our antiemetics can do that. So you just got to be wary of that. And then again, if you have a significant acute ingestion that you're pretty sure about, because it's either an intentional suicide or it's just high in your differential, then you want to start chelation therapy. And then the chelators that we have for this are British anti-leukocytes, or BAL, which is in the US, that's the only parental form that we have available for arsenic. It's available intramuscularly. It's hard to give Suxamer or DMSA if they're having a lot of GIs, right? They're already vomiting, having diarrhea. How much are they going to absorb? So we're pretty much left with BAL. And then once they can tolerate Suxamer orally, then we'll switch to that, because it's BAL can have a lot of different side effects. I'm not sure what chelators you guys have here. I don't know if you have DMPS or do you have BAL. Anybody know? So there, in a lot of countries, we'll have unithiol, also known as a DMPS, and that can be given either IV or oral. So that's a chelator that's available in Europe and several Asian countries. We don't have it in the U.S., and it's a compounding pharmacy makes it.
They have BAL in Turkey because we used it before for a patient in Georgia.
Okay. All right. Now our last GI case that we're going to talk about, again, occurred in last 2 decades ago, right, 2006. He had a 44-year-old male who said his name was Edwin Carter, and I got that in parentheses, and you'll see why. Presented to a hospital in the UK with vomiting, profuse diarrhea, and weakness. And this illness started, a couple of days before in the evening of November 1st. He couldn't walk without assistance. And was having a lot of abdominal pain, and so he asked his wife to finally call in an ambulance. So he gets evaluated there at the hospital. He gets initial diagnosis of gastroenteritis. His initial blood test showed essentially normal platelet count. His hemoglobin and his white count were a little bit high. His BUN and creatinine were a little bit high, and thought that, well, he's just kind of hemoconcentrated, a little pre-renal, so he's dehydrated. And he got started on Cipro for presumed gastroenteritis. Then he tells his providers that really his name is Alexander Litvinenko. And he happened to be a former Russian security, a member of the Russian security service, which is what the present name of the KGB is. He had defected to the West about the year 2000, and the day of his illness, he had met with a couple of Russians for lunch. So, anyone familiar with this case? Yeah. So I gave it away. Litvinenko, yes. So broad differential now, right? I mean, as toxicologists, we love the Russians. They give us all kinds of new things to think about with carfentanil gases and ricin pellets and now in radiation. So, masters. Over the next few days, his blood counts started to fall to abnormal levels. And this obviously brought in a lot of concern as far as what's going on with this. Why is his blood counts getting lower? That he's getting leukopenia, low platelets. And so his wife asked, his attending physician or consultant physicians whether this could have been results of poisoning. He happened to be a pentathlete, as well in his earlier days and was still quite athletically vigor. But the attending at that time, told her the symptoms were common, and an infection, that poisoning was, not likely. A new consultant kind of took over the care then, after he'd been there for about 10 days. And they continued to try to look for additional causes of what could be going on. They contacted the poison center, poison unit there in the UK, and discussed a potential differential. Dr. Victoris, this new attending, had thought that all this bone marrow suppression was going on, was kind of familiar to him and patients that he had previously taken care of who were getting intensive chemotherapy for their cancer, and then also getting total body irradiation, prior to having a bone marrow transplant because they had like leukemia or something like that. And so he became really suspicious of that. So he talked with his radiology department about you check for radioactive sources of poisoning, and they came up with their Geiger counter and kind of went over everything and didn't get any activity. And then he started losing his hair. And so when he gets his alopecia, then that kind of made them expand their differential a little bit, especially, and made them think about thallium, because when we think about a toxin that can cause alopecia, hair loss, then certainly thallium kind of rises up in the differential. But when we think about thallium poisoning, you do get GIs. Is this going to play? How do I get that to play, Ziad? Do you know?
No, there's nothing.
The video? No mouse? Okay. So you do get gastrointestinal, effects. You get alopecia, which he had, but then you also get usually a really painful peripheral neuropathy, which he did not have. You usually get encephalopathy, but he did not have that. And it also does not cause bone marrow suppression, which is what was, really remarkable about this. His ANC, was below 500, and even, lower. And so it didn't exactly fit. With that. So then they started thinking, well, could he have gotten radioactive, thallium? And, we give radioactive thallium, right, for our cardiac markers, right, when you're getting a thallium test on somebody. But it's just a little bit of radiation. So they're thinking, well, is it possible that somehow they could give him this massive amount of radioactive thallium, and that's what caused it, because we're not detecting, any radiation, on him. And so that was kind of in their differential. Yeah.
You want to try one time? I can just give it one shot.
Sure. It's a video that Ziad had found.
Actually, yeah, you play the music. So this is actually, I want to step back.
Sure.
This is a video that was made by Syrian doctors in refugees in Lebanon when there was a family that was poisoned with thallium in cookies.
Oh, I didn't know that.
Died, and about 20 people were affected. It's a sad story because the mother who did not get affected was because she did not want to eat. She saved the cookies for her children because of the hardship in Syria. And she survived, and she is not safe.
Wow.
So they made this video on their own to raise awareness about this. It's really
And so they decided to go ahead and start treating him for thallium and give him the thallium chelator Prussian blue. This case, maybe this was some sort of weird thallium isotope that they weren't aware of that could have resulted in the adverse health effects. Even though his thallium level, he had one level that came back just like a little bit high, and then a subsequent level came back that was, nothing. They decided to go ahead and say really we didn't have much else at that point to offer him. Then he got transferred to a higher level of care when it became more and more apparent that this was probably some sort of poisoning event. He got placed under armed guard. The investigation got transferred to Scotland Yard to counterterrorism. And then they started looking at taking more samples and then taking it to higher authorities as far as looking for radiation in him. He ended up dying then on November 23rd, and just right before his death, they ended up finding that he was poisoned with polonium, a radioisotope, which we'll talk just a little bit about. And so polonium is a little bit different in that it emits alpha particles. And alpha particles, again, this is intimidating for me talking about radiation when I got one of the world's experts here right beside me, Dr. Kazi, but I'm sure he'll correct me if I'm wrong. And so alpha particles are not really, don't penetrate very well. So like even a piece of paper or your skin can stop alpha particles. And Geiger counters are not set up to detect alpha particles. So they're looking for gamma radiation mostly, and they emit very little gamma radiation. And the thing about polonium, it also is only produced in significant amounts in state-regulated nuclear reactors. So it kind of tells you that it was some sort of a government or state-sanctioned to be able to get someone get that polonium and then be able to give a toxic dose to somebody. And so what had happened is that the investigation revealed that it was probably at a restaurant that he went to with these two Russian agents, that they had sprayed the polonium into his tea that he was drinking, and that he consumed it then, and then that internalized it. And so it became internalized, and so that's why he could still get the effects from the radiation because it absorbed into his body as opposed to, normally it wouldn't be able to penetrate even our skin. You want to play this video too?
Some type of radioactive material, he or she can be exposed to the radiation emitted by this source. However, he or she does not become contaminated. One way to think about exposure is to think about X-rays. When a person has a chest X-ray, he or she is exposed to radiation, but does not become contaminated with radioactive material. A person can reduce his or her exposure to radiation if he or she is shielded in some way from the radiation. For example, if the person is behind a concrete wall, or if the radioactive source is inside of a lead container. In order to become contaminated, radioactive material must get on the skin or clothing or inside of the body. For example, if radioactive material is incorporated into a dirty bomb, a conventional explosive such as dynamite that has been laced with radioactive material, then people could become contaminated when the device is detonated. Radioactive material on the outside of the body is called external contamination. When a person becomes externally contaminated, simply removing the clothing can remove up to 90% of the contamination. Gently washing the skin and the hair can remove most of the remaining contamination. If a person ingests or inhales radioactive material, it can become incorporated in the organs of the body. This is called internal contamination.
This is what happened to him.
When a person is internally contaminated, depending on the type of radioactive material with which they were contaminated, certain medications can be administered to speed up the rate at which the radioactive material is eliminated from the body. Such medications include Prussian blue and DTPA.
So, the aftermath of this, one of the things they were able to find were 3 distinct contamination paths. One was Limvincto, whenever where he would go, he probably still had like someone's mouth and had washing his hands and then, was touching things, was contaminating this with the polonium. And then also these 2 Russian agents, that wherever they had gone, they they thought that maybe they didn't know what they were actually carrying. It seemed like what they were was leaking. They think that they actually had tried 2 other times to poison them, but it just didn't. They didn't have the right scenario to do it because they found it in other hotels that they had stayed at, in previous visits, like the month before to the UK. And they found it on the airplane. They found it again in their hotel rooms, the restaurant where the poisoning occurred. And so they're able to link it to these 2 guys, quite readily. And so this became, a public health problem. They had to look at the people who were taking care of him in the hospital as well, because they were potentially getting exposed, to radiation, and had to do all those assessments. But in general, they thought that no one was going to have a significantly increased risk of adverse health effects, from this. The Kremlin and Russia, denied all accusations that they were involved with this, and then has refused to do extraditions of other citizens for trial. So if there's going to be a trial, it's going to have to be here in Russia, and so nothing really developed from that. Any questions about this case or any of the cases? I think we'll probably stop here then. Okay. Yeah.
Even if it was detected early, would he be treated?
I'll let you answer that.
It's inevitable death, I think.
So I think polonium, there's no treatment for it. There's some mice studies looking at BAL, but the dose he got was lethal. So there was no way. So he had a very super lethal dose of radiation exposure.
The effect of the contamination where the spies went and where he...
So there were 28, so I'll tell you about the healthcare providers. There were about 28 healthcare providers who took care of him using just level D PPE, using standard precautions. And they measured urine samples on them to see if they've internalized any polonium, and they found nothing beyond the usual background levels. So that was good. And whatever levels they found, they were higher a little bit in the janitors, who are basically cleaning the trash can or changing the sheets, and the nurses. The least exposure was on the contamination was on the doctors, because probably they are in least contact with the patient. So basically, they found some levels that were within accepted occupational limits. Nobody's had any issues. There were about 150 or 200 U.S. citizens that happened to be in these areas that ended up being tested in the U.S. and they were fine as well. So.
Yes.
I have 2 questions. First of all, the colchicine oral, will this same effect of the IV colchicine?
So usually it's going to take a larger dose, but yes, it can have the same adverse effects. So the early GIs that you get, from getting too much colchicine, may limit the amount that is absorbed. So it can be a little bit protective, but if you get it IV or IM, you're getting 100% absorption, so that it's certainly a more lethal route. But what oral can certainly cause death.
The other question is different. There is a high suspicion of the patient that he may be exposed without any symptoms. Is there any...
to radiation? To radiation?
Radiation, chemicals, medication, IV, but there is no symptoms at all. Is there any role of emergency department or toxicologist or labs? Is there any specific investigation that we can do to discover early before the symptoms come?
That's a pretty broad question. It kind of depends a little bit on what you're suspicious, of. And he comes in and he thinks he's just poisoned because he's a Russian agent, and I know they made me just drink this stuff, right? No, I mean that's.
I had similar case.
How did you handle it?
We contacted the labs and we did all the investigation that we have in the world. Because he was a high-level guy. But I'm asking now in the future. If
it's an acute ingestion, you could think in your minds or something I could do to prevent absorption. So I'd go down that pathway. Do we think that charcoal, something like that, could help somebody, like that?
Radiation is easy. The radiation is easy because you can detect it with the Geiger counter. The trick here was that was polonium was a unique alpha emitter, but if this was hithian, just a cesium, you can just wave a radioactive. You can wave a Geiger counter on the stomach, and you can. Metals are, metals you can do like a 20. Typically, when people come to us with these complaints, we do a heavy metal 24-hour urine collection for heavy metals.
Yeah, so there's no magic kind of like test to screen for everything. So you can have certain panels that you wanna order based on symptoms usually. I don't know if NMS has. There's a lab in the U.S. National Medical Services that we send a lot of our tests to, and they have a lot of panels that by cluster of symptoms you can send. I don't know if they have a homicide panel that you're aware of. I wouldn't be surprised if they do. If they don't, they're very, very creative and very good. But again, you're kind of telling them what you want, to test for. So if you have someone who comes in with a sympathomimetic toxidrome, you can kind of tell them that, and then they have a panel of tests to look for, cathinones or bath salts, amphetamines, cocaine.
Yeah, you have to have some symptoms.
Yeah, you have some symptoms, or where they work, or so because we see a lot. We have a clinic where we see people, and we see a lot of people who are what we call worried well, and they think they're being poisoned with something, and so you kind of talk to them about it and what a differential is, and then you decide whether you want to send something based on what their symptoms are. But if you're thinking about poison with the Russians, I mean that's a broad differential.
All right, thank you, Dr. Morgan.
Yeah, great questions.
All right, so let's take a break.
Okay, a bit too high, lower it a little bit. Okay, so the next cluster we are going to face together is the cluster of skin problems, which is probably the least favorite of emergency physicians. Emergency medicine doctors, they don't like skin problems because we don't know enough about them, and we just want to send them home and have them follow up with dermatology. But I am going to try to go through this with you and see what we can do to look for potential CBRN exposures that lead to skin problems. This is a real case that we took care of when I was an intern in Atlanta, so this was not my case. This is a patient that came to our ER, but I was there, I happened to be working in the ER as an intern. He was Spanish speaking, and he said he has this hand. This is what happened to his hand. And he was hurting, and literally he came with this hand. He wouldn't tell us, what's going on. He said that, we asked him, did you burn your hand with a fire? He said no. Did you burn your hand with electricity? He said no. Did you, crush it with some trauma? He said no. He refused, he denied all of this. We said, did you put your hand in an acid or a base? He said no. Now, he was a janitor at Georgia Tech University. Now, at the time, I was not, sensitized to CBRN, or I didn't have, but my colleague, Michael Schwartz, who's a toxicology fellow at Emory at the time, he was a very smart man. He was very clinically solid, and he suspected that this could be a radiation injury. Because this person works as a janitor at Georgia Tech University where they have radiation sources. So he thought maybe he handled a radiation source, and because of the delayed onset of injury from radiation, forgot that he touched it, and now he has the radiation effects. And he was very astute about that, so he called the FBI, the Federal Bureau of Investigation, Georgia office, and they went to the Georgia Tech University and did a radiation survey looking for potentially the source on the floor or in a trash can. And they could not find it. They could not find anything. But they published it as a case, as how they investigated this. The patient had to have a finger amputation, like hand ray amputation, and recovered. And it turns out that he actually was lying to us. He was actually an electrical injury. He was stealing copper wires from the rail and got electrocuted. But he did not want to say that because he was stealing it. But I like this case a lot. I've used this case every time I talk about this because it really highlights the importance of maintaining a broad differential and getting a good history, which Michael Schwartz did in this case. He asked the person, where do you work? He knew it was Georgia Tech University. He realized the university, like Georgia Tech, does indeed have radiation sources. And went to the differential of biological, chemical, radiological, and thought about radiological. If you don't do that, the agent-host environment, you will miss things. That's just a tool for us to retrieve information from our brain. And that's what we're going to do today by looking at the skin together. The skin has the epidermis, the dermis, the hypodermis. The skin is important for us for many reasons. It protects us from multiple factors, toxins, bacteria. It can also keep heat in our body, keep water in our body. And when we lose the skin, we lose all these protective functions. Now, there are burns that affect the integrity of the skin, but there are also rashes that, although may not necessarily cause a significant skin deficit, but they will have skin manifestations. Okay? The differential is really broad, guys. It's really broad. It could be an infectious disease, a thermal burn, an electrical burn, a cold-related injury can cause a skin damage, an allergic reaction, so an immunologic process can cause skin damage, or chemicals can do that, and don't forget radiation. And we will go through these different scenarios and appreciate what is common or what is different. Let's think about the biological question a little bit. You know, here we are looking at usually rashes, okay? And we are looking at potential causes for these rashes, okay? If not a rash, sometimes you see maybe a lesion. You can see a lesion, which is kind of a rash, but it's more like isolated or specific. And we have to think about what potential causes for these rashes. You know, bacteria, for example, you know, are definitely an important cause of these rashes and lesions. Plague is a good example. Anthrax is a good example. Tularemia. These three agents, which are category A biological agents of concern, cause skin manifestations. When you think about viruses, of course, many viruses cause rashes. The ones that are concerning, for example, smallpox, viral hemorrhagic fevers, okay? Viral encephalitis type infections, all of these can have some rashes with them. Now, toxins, on the other hand, like ricin and botulinum toxin, do not cause rashes. Toxins are less likely to cause rashes, except, for example, if you're thinking about a botulism case where you have a wound infection from somebody who's injecting drugs or some other type of wound, gets infected with Clostridium botulinum, like you see on the slide, they can create a toxin. Now, poison ivy is an allergic type dermatitis. So we got to talk about that a little bit. That's a good question, good point. So you need to appreciate the shape of this rash. Is it macular, papular, vesicular, ulcers? And also the pattern of spread is very important in infectious rashes. You know, a chemical rash is not gonna spread in a centripetal or centrifugal fashion. Infectious processes will do that, and you have to appreciate that. And patients with a rash from an infectious process or a skin manifestation of a rash of an infectious process usually have some sort of other associated complaints. They're usually in incubation period, of course, that's tricky, where people may or may not be infectious, where people may or may not have any symptoms, and may be several days and may vary from one person to the other. Plus, you have to think about the sick contacts that have been involved as well, so asking history about other people that have a similar rash. These are clues to take you down the biological path. So follow these clues, ask about them in your history, ask about the sick contacts, ask about the recent travel history. What's going on in the world? Are there other infections that are ongoing in the world, or epidemic or pandemics? Does the patient have any prodromal symptoms? Do they have other symptoms like fever, headache, sore throat, runny nose, myalgias, arthralgias? So when you go through this history and physical exam with the patient, if you find these, then you ought to be thinking more of a biological cause for the illness. For example, smallpox. I love smallpox because it has a beautiful type of complex of prodromal effects, incubation period, and rash. The incubation initially is 7 to 19 days, but the average is 10 to 14 days. This is the incubation period. And typically, during the incubation period, patients are not contagious. Okay? Then they develop some non-specific symptoms for 2 to 4 days. That has a very high fever, head and body aches, occasionally vomiting, and they could be infectious in this time, but not as much as when they actually have the rash show up. The rash has an early phase, which is about 4 days. And here you have these small red spots in the mouth that disappear, leading to the rash, these same type of red lesions all over the body. And they actually start on the face and spread on the arms and legs, and then the hand and feet. The important thing about smallpox rash is that it rapidly spreads all over the body. And then when the rash shows up, the fever starts going away. The other thing that's important that you see on this slide is that all the lesions are at the same stage. So remember, this rash spreads rapidly from the mouth, disappears in the mouth, and then the body quickly. And they're all together like a symphony, like an orchestra. This is different than what other infection? Chickenpox. Well done. The second phase, the 10 days phase, is where you have the pustules and scabs. Again, all of these phases are infectious, or contagious, and the contagious, that's a good term, the contagious period goes away as your scabs, as your rash scabs off and then goes away. So typically by the end of the second week, after the rash appears, most of the sores have scabbed over and you're no longer contagious. And some pictures, historical pictures of smallpox rashes from the CDC website. 1978, I think, is the last one. And we hope we don't get new ones, but we have to be alert, and we have to differentiate a smallpox rash from the chickenpox rash. You see here, there's no orchestra. The next example I want to talk about is plague. Plague is Yersinia pestis. It's a category A agent of concern. And it's interesting because the rash is a little bit different. It's no real rash. It's not a rash per se. The most common form of plague is bubonic plague. And you can get it by a rodent bite or infected flea. And the bubonic plague is the most common. And you see those buboes. They call them buboes in that groin area. So if you see something like that, you must recognize it. If you see that, you should look at it and say, okay, looks like plague. This is a bubo. And if you see the fingers with these kind of emboli, this is septicemic plague. The interesting thing about plague is that it's not transmissible from one person to one person except one condition. Which one? Pneumonic plague. Pneumonic plague is transmissible, but bubonic plague is not. You have to be exposed to it from the tick, the flea, the affected flea, or the bite from the rodent. Tularemia, on the other hand, is different because it does not have a person-to-person transmission. Tularemia is due to Francisella tularensis, and this is basically a bacteria, and you get it by handling contaminated animal tissues or fluids, or by the bite of an infected deer fly or mosquito or tick, or with direct contact or ingestion of water, food, or soil. The classic scenario here is a hunter that, for example, killed a deer and was working on getting cutting off the meat and skinning the deer on their own, and they get a little cut in their skin or something, and they get infected. And again, no person-to-person transmission. So taking a history about what they do not just occupation, also hobbies, may take you down this route. And then when you look at the lesion, though, here, it will be a little bit more challenging than plague. Remember, there are multiple forms. There's intestinal, pneumonic, typhoidal, and the cutaneous lesions. The lesions are tricky because they're not, they don't necessarily, they're not like a rash, and they're usually ulcerative, typically. So you see here a papule on the left upper corner. On the right corner, you see how it ulcerates. One hint in tularemia is the glandular disease. So it's an ulceroglandular disease. And the gland behind this person's ear on the neck would be a bit more typical and will give you a hint that this is tularemia. But if you don't have this gland, really you're just looking at an ulcer on the body or a papule. Anthrax is another important rash or lesion. This is Bacillus anthracis, and it evolves from a vesicle to a pustule to a necrotic ulcer. And it evolves over several days, over 15 days. It is also associated with surrounding edema and erythema. So when you see that, erythema, edema, with the progression over 2 weeks, you have to think of anthrax. Also, you have to think of anthrax when you do a chest x-ray and you find a widened mediastinum, for example, in somebody who has an infection, because it causes mediastinitis. And potentially cutaneous anthrax will have these necrotic ulcers. And I've pursued this in my career. One time, I had a patient that had like this lesion that was still early. It was more like a pimple, kind of pustule. And the reason why I pursued it, not because of the rash, I pursued it because he came in with a respiratory illness, and we scanned his chest. And the CT scan result said that he had a widened mediastinum and some mediastinal lymph node enlargement. I asked him what he did, and he told me he's a farmer. So I got all excited. I said, perfect, I got my first anthrax case, I'm gonna be famous. But I asked the question, farmer, maybe horses, got some exposure to the horse or, cow. This is in the US. But again, it wasn't, so I was wrong. It wasn't anthrax. It was just another cause of mediastinal lymph node enlargement, and that pimple was just a pimple. But you have to be aware of what's in your environment. In Georgia, Republic of Georgia, for example, anthrax is common. So you have to be alert to it depending on your environment. I don't know about Turkey, if you see anthrax cases in Turkey, natural anthrax with cutaneous or pulmonary. So it depends where you are in the world. You do see that? Yeah. We see a lot of anthrax cases. I'm just kidding, but they're actually brought to our attention as brown recluse bites. The brown recluse is a spider in the US. It's also potentially around the world too. But the brown recluse is a recluse. Recluse means a shy spider. I don't know why they accuse the spider of running around, biting people. But they come to us and say, I've been bitten by a brown recluse. And again, the brown recluse will cause a lesion similar to the cutaneous anthrax. So that's another part, the similarity to cutaneous anthrax, brown recluse, and also nowadays, methicillin-resistant Staph aureus infections. And the ones we see in Atlanta, they come and tell us, oh, this is a brown recluse bite. Most of these end up being a Staph aureus infection. But they accuse the poor spider. So what I usually say, did you see a spider? If they say they haven't seen a spider, I say, okay, it's Staph aureus. Well, they cause bites, but not as common as you see these Staph aureus infections. So it's difficult to differentiate, whether it's a spider bite or it's anthrax, etc. But this one is actually an anthrax because you see the necrotic ulcer and you see the redness and erythema and swelling around it. This is more typical of anthrax than a brown recluse spider bite. But again, the differential here is really broad. This is not meant for you to read it, but just want to show you how broad the differential of these type of lesions is. So moving away from the biological area, let's think about other causes of more severe skin damage, like basically tissue loss, what we call a burn. The burn, again, could be thermal, could be electrical, right? Could be radiological. it could be allergic, it could be cold-related. All of these can cause tissue loss and a burn. The burn usually is assessed in terms of its depth and its size. The depth is important because the deeper the burn, the more vital structures are lost in the dermis, epidermis, dermis to the hypodermis. And the deeper you get and you lose more of your hypodermis, you lose your stem cells that are supposed to come back and heal the burn wound. And that means a deep burn will not heal and will require a skin graft. Burns that are less deep, more superficial, they can heal with potential for contractures sometimes, but they may be able to heal because they have enough stem cells in there. The size of the burn is important as well because a large burn is going to cause systemic effects from fluid loss, heat loss, risk of infection, and even systemic effects on the lungs, on the kidneys, and protein wasting that can happen from these large burns, let's say 20% body surface area and above. Finally, the burn depth will also affect whether the burn is going to be insensate, where you lose sensation if you lose the sensory nerves, or not. So this is the example of a superficial burn, or first degree. There is no tissue loss, there's tissue inflammation. The cells are angry, that's why it's painful, but the cells are not dead. It's a transient situation, transient injury or stress on the cells. The partial thickness burn, here you have some loss of dermis, and here you have to think about how deep it is. It's very painful because the sensory nerves are injured, but they're still there. It's wet because it's got all the cell content is leaking, and it can actually get infected, and it can also produce loss of water and heat. The full thickness burns are usually insensate because you've lost the dermis and now you're actually deep and you're gonna actually develop contractures and you're gonna need grafting. The burn itself is pale because it also lost the capillaries. And the best way to detect a full thickness burn is to look carefully at the erythema. If it's red, it's not full thickness. If it's pale, it's full thickness. If you get a probe and you touch it, if they don't feel it, it's a full thickness burn. Why it's important to differentiate that again? Because of the prognosis. A full thickness burn is going to require a graft. Now the electrical exposure can cause burns as well. Remember that. And those burns though are interesting because, for example, the electrical current can produce heat. The heat can cause the thermal burn, but then deep, you also have the electrical current causing deep tissue damage that is not visible to the outside. This is a guy we had in Alabama when I was in UAB in Birmingham. This man has thermal burns and has electrical burns. You see, you see the current on his chest. This is the one of the wounds of the electrical burn. And what on his back is a thermal burn because his clothes caught fire. Okay? And here you have more issues to deal with because you have rhabdomyolysis from the muscle damage, kidney failure, compartment syndrome, many other things here beyond just a thermal burn issue. So he had all of these together, unfortunately. He was a mechanic and then got electrocuted. Cold weather can cause tissue loss as well. So, you have to ask, were you exposed to a cold environment? Cold and wet environment can lead to these frost bites. Okay, this looks like a burn to me. Could be also a thermal burn would look like this. One is hot liquid, the other one is cold environment. Or chilblains. Chilblains were basically in some people, they have exposure to a wet, cold environment. They can get this reaction. This is a woman there on the right, I think who she had her feet in an ice bath, caused this chilblains. Or frostnip, which is a very minor, early response to exposure to a cold environment that can eventually lead to beyond that, to more deeper burns like a frostbite. So as you see, a burn can be due to all of these. And you have to go through the thought process of what could it be in this specific patient. And you gather clues from the temperature, from the history, and they'll tell you, you know, yes, I spilled some hot liquid on me, or not. And remember our guy Grady, he denied being exposed to electrical current, he denied being exposed to liquid, hot liquid, he denied being exposed to chemicals. Is he allergic to something? Unlikely to cause severe manifestations, usually contact dermatitis like this one that Ala mentioned earlier with the poison ivy or poison sumac or poison oak. They cause these typical rashes that are kind of like a linear a little bit with pustular. And yeah, potentially there's a history. Sometimes you don't have a history because people don't remember being exposed to the plant. Or sometimes their pet is exposed to the plant, and then they rub the pet, and they get it on them that way. And these are annoying rashes because they're very pruritic, and they are tough to get rid of. And they're due to this substance called ursochiol, which is in these plants. Don't forget about chemical exposures to metals, like nickel allergy will cause that. Somebody on their belt buckle area will have the allergy, or on their watch. So the location of the rash can give you some clues as well. And allergic rashes can be severe with erythema multiforme or even Stevens-Johnson, and those require burn care. The Stevens-Johnson case would require to be at the burn center. Chemical burns, on the other hand, are going to cause a more burn-like picture, like a thermal burn. And chemical burns can be liquefactive or coagulative. What does that mean? Liquefactive is the chemical digests the tissue as it penetrates deep. So you have deeper and deeper liquefaction of the tissues. An example of that is bases. Bases can do that. Acids, on the other hand, they cause a coagulative burn because as they contact the skin, they cause a coagulum. And the coagulum crusts it off and kind of stops the deep penetration of the liquid. Okay? So acid versus base, coagulative versus liquefactive. Bases are usually deeper in their reach than acids. Now, we think of chemical burns from acids and bases, but that's not the only way you can burn the skin with a chemical. Think about sulfur mustard, think about lewisite, phosgene oxime, particularly sulfur mustard and lewisite. They are not acids or bases. That's not how they cause the damage. And I shared with you yesterday some of the mechanisms that the way they do it. For those of you who did not attend the lecture yesterday, current understanding of lewisite mechanism of action involves genetic changes, so genetic expression changes from the lewisite that lead to the unfolding of proteins, and the unfolding of proteins causes the clinical manifestations. And the way you stop that is potentially by preventing the unfolding of the proteins. And there are some countermeasures that are being developed to do that, but an old countermeasure is cold water. This is why when you burn yourself, you put your hand on the cold water, the cold temperature prevents the unfolding of proteins. That's why it works sometimes, limiting the size of a burn when you stick your hand under cold water. So vesicants, again, like sulfur mustard and lewisite, are going to cause burns, and they're not acid or bases. And the burns from chemicals usually are immediate. Okay, usually they're immediate. The delay in the onset is not typically a chemical burn. Okay? Radiation, on the other hand, is a classic example of a delayed onset burn. So anytime you have a delayed onset burn, think radiation. Most of these chemical burns are local in their effect, although some have systemic complications. Classic example is what? Hydrofluoric acid. It causes a chemical burn and it causes systemic effects. We also have special cases that we know as toxicologists. A yellow burn. A yellow burn. What causes a yellow burn? Which acid? Nitric acid. So, White phosphorus is a special case. I mean, we have some special chemicals too that we need to know about. This is the guy I had in Grady. This is a sulfuric acid battery. So he, I don't know, like messing around with the battery, splashed him with sulfuric acid. And the reason why I show you this is you see the crust. I don't know if you can see it. See the crust on his forehead? This is the best example I could find of coagulative necrosis. That's a close-up. And you see it looks like a thermal burn, right? What's the difference between this and a partial thickness burn? But the history here is important. And of course, you have to look at the eyes, because the eyes can also be affected. And you know, you have to irrigate those eyes when this happens. And this is the guy that he did well. And you know, that burn on his forehead is really managed like a thermal burn. There's nothing else you gotta do. So we don't do much. Toxicologists with this, you know, you don't need a toxicologist for this case. All you need from me is to like tell you that what is the pH maybe, or what is, they call us to find out what the chemical is, because we have the resources, we can look it up online. This, on the other hand, is a deep liquefactive burn. This is a patient of Dr. Morgan when he was in Charlotte, North Carolina. And you see how the beefy red liquefied burn on her face. Now, on the other hand, hydrofluoric acid, as we said, is going to cause systemic effects. It's not a great acid in terms of the burn itself. I mean, the burn itself is not that bad. But the pain is very severe. Why is there so much pain, Ala? It goes to the bone. It's in the bone. So fluoride ion is small, so it penetrates. The acid is not the main issue in hydrofluoric acid. It's the fluoride and the bone causes hypocalcemia, as you said, and hypomagnesemia. And then you complicate the whole picture with hyperkalemia. And hyperkalemia leads to the cardiac arrest. And of course, hypocalcemia can lead to torsade de pointe or polymorphic ventricular tachycardia. And the management is what? Calcium, calcium, calcium, depending on the severity of the lesion, of course, and the route. You know, you can pick intradermal, intraarterial, intravenous, depending on the severity. Topical, on the eye, by nebulizer. It really depends on how severe the case is. I've never seen a very severe hydrofluoric acid case. The ones I've seen were more from low concentration hydrofluoric acid in the 10%, 15%. And they typically have pain. And the way I manage those is by either topical, if I can get away with it, but it's hard to get away with it. Most of the time, they keep having pain and they don't feel better. So you have to do the intraarterial calcium gluconate.